Okay, good morning. How is everyone doing? Can you guys hear my voice? Okay, so welcome to the 29th lecture of Dr. Haider Step 1. Um, in this group of lectures, we are very close to finishing neurology, and we have finished neurology, neuroanatomy, neurophysiology, and we have finished neuropathology. Okay, we have finished otology, and that's that. And today we are going to target on finishing ophthalmology, and we will start with the pharmacology portion of the neurology. Hopefully, that's what we will do. And before we begin, I just want to know how the regular question. I'm sure you guys know exactly what I'm going to ask right now. It's about the U world questions. How many U world questions are you guys doing? Is it hard? Is it difficult with what's going on? That's what I would really love to know. How the U world questions are, how many questions you guys are doing. So I would like to keep some track on what's going on. So if anyone would be kind enough to um, let me know. Okay. How many questions are you guys doing right now? 10? Okay. Okay. 20. 10, 20, 30. Okay. Not bad. Okay. So it's the regular amount. Okay. Autology questions are hard. Okay. Autology questions are hard. Which question from autology did you find difficult? I'll help you out. Not covered in first aid. Sure. Which questions about autology did you find in U World which were not covered in first aid? If you have to come across questions about the nerve supply. Okay, so if you have to come across the questions which are not covered in first aid, then high possibility that these are absolutely new questions. Okay, high possibility that these are absolutely new questions. And the thing about new questions are being added each and every month in UWorld. And the thing is, they are questions which are directly added from the previous exams. Okay, so as we said before, we solved the questions which were close to around 3,200. The rest of the 100 questions which were added were not looked upon very closely by us, so we would be doing that. So if you can give us an example about what type of questions you came across about referred pain. Okay, so if you received a question about referred pain, then it's not from your knowledge regarding otology. It's from your knowledge regarding the dermatomal distribution. Can you give me an example, please? Do you have the question in mind? Do you remember the question? Okay. So most of the time, if the question was about referred pain, then the question was not directly taken from the otology text in first aid. The question was directed from the dermatomal distribution of the nerves. So that could be it. Okay, because the amount of Arnold nerve. Okay. Okay. Do you guys mean the auricular branch of the vagus nerve? Was it regarding to that one? The auricular branch of vagus. Okay, so if you would be kind enough to let us know the questions, then we can maybe break it down for you. Okay, Having said that, how many other students received questions which were common or uncommon to our discussions before we begin our recapitulation for today, or our revision and recapitulation for today? How many questions did you guys receive that were common to our lectures? Can you guys hear my voice? You got a question on meningitis? Okay. Conducting hearing loss. Okay. So my question was, how many questions did you guys receive that were common to our discussion? That is regarding brain tumors and everything else. How many questions did you guys receive? Were they common or not common? Our discussion from first aid and URL notes. Okay. Okay, then we can begin with our revision and recapitulation for today because we have to finish neurology. Okay, so if everyone is on board while we wait for the rest of the other students to come and join, are you guys ready to start your revision? Is everyone ready? Okay. Okay, great. So what we will be doing is we will be starting with neurology, and we will be revising the previous topics that we discussed yesterday. And I would appreciate if every one of the students could contribute by letting me know the answers in the chat box. Okay, and we have a good news. Okay, we have a good news with which we want to start the lecture for today. Okay, the good news for all of us is that we promised we were going to subscribe to Physio, and we will. But for the time being, since we will be subscribing to Physio, let's say around next week, okay, next week or the week after, depending on when we start pharmacology or microbiology, okay. But the good news is, if do we have any fans of Dr. Najib over here? Do we have any fans of Dr. Najib? Have you guys heard of Dr. Najib Step 1 lectures? Okay, Dr. Najib Step 1 lectures. Okay, so the good news for every one of us is that from next week, okay, from next week, not only are we going to subscribe to physiology, we are also going to subscribe to Dr. Najib. Okay, we are also going to subscribe to Dr. Najib. Now, the thing is, I do not need you guys to go and watch his video, because always remember that regarding USMLE Step 1, okay, less is more. Okay, less is more, meaning the less resources you use, the better you will be. Okay, so if you are just using our lectures to read first aid and study first aid and doing UWorld and watching Pathoma, it's 99% enough. Okay, it's 99% enough. Okay, for the rest of the 1%, if you guys are interested, if there's any video which you think you would be interested in to go and watch from Dr. Najib, just to clear your basic details, nothing else, because Dr. Najib videos are extremely long and they're very time consuming. Okay, so just for your sake, just for the sake of our students who would be interested to watch Dr. Najib, okay, just for the sake of our students who would be interested to watch one or two videos from Dr. Najib. Okay, the lectures are very long. That is very accurate. They are very, very long and they're very time consuming. Okay, but if you want to watch the lectures of Dr. Najib, okay, if there's anything that you would want to go and watch and then to clear your basics and everything, okay, we would provide you the subscription. Okay, obviously we would have one subscription for ourselves, and what we would be doing is every week we would choose a couple of students. Okay, every week we would choose a handful of students who can access the lectures And after that, we will change the password, and then the next group of students can go and access the lectures. And if there's any lecture you are and if there's any lecture you want to go and download, you can download it from over there. So that's another deal, and that's another good news which we wanted to get you guys is Dr. Najib. So we are trying to provide for you physio, we are trying to provide for you Dr. Najib, and all of these will be provided for you guys next week. So please make sure that you guys do not please make sure that you guys do not miss out on next week's lectures. Okay. BNB videos on the other hand, BNB videos are, the thing is, they describe first aid exactly like how we describe first aid. So there is no not much difference on what how BNB video goes and how we go. So that's the reason we won't be subscribing to BNB video. Once again, do not use a lot of resources. Do not use a lot of resources. First aid, UWorld, and Pathoma is enough, just for the fact that if anyone is interested to go and watch Dr. Najib or Physio, okay, just for their interest to clear certain topics, not all topics, to clear certain topics, to clear the basics or to clear the confusions from certain topics, we would be providing you Dr. Najib's subscriptions, okay, for completely free, okay, for completely free. So we would be doing that, but we do not want you guys to waste your time watching those videos. Instead, you could be doing the UWorld questions. That's what we want you guys to do. If you guys have free time, only then go and watch some of his videos. Did I make myself clear? Yes or no? Did I make myself clear? So should you guys use more resources or less resources for step one? Less resources. Okay, good, good. Okay, good. So less resources, but just for the fact that we want to provide you guys with certain subscriptions. Okay, that's why we are providing it for you. And it's been 2 months into our lecture, more or less. Okay, I mean, we have just finished 1 month and 1 week, and we are stepping into the second week of our second month. Okay, and we wanted to get you guys something as a gift. Okay, it's for staying with us for so long. So that's what we are doing. Okay, and obviously our friend user one over here has sent us the link for Pathomas. Okay, we would have shared it with you, but then we have Dr. Gianni over here who's already sharing the link. So please, if you need to go and watch the Pathoma videos, you can go and access it through her. Okay, so now we have access to all the high yield resources. Okay. Okay, so with that being said, okay, I think we have spoken enough on USMLE and resources and this and that. Okay, and our good news for Dr. Najib and our good news for physio for next week. Okay, and we are extremely grateful to Dr. User One for sharing the Patoma videos. Okay, so we are all on track. Okay, so everyone is happy, and with this happy news and with this positive energy that we have today, let's begin our revision and let's begin our recapitulation. Okay, okay, so our first question goes for the for the spinal cord defects. Okay, so you have a young child who comes to you with asymmetric flaccid paralysis, and the child has fever. Well, what is your provisional diagnosis? Fast answers, please. If the child comes to you with asymmetric flaccid paralysis without fever, what is your diagnosis? Without fever. Asymmetric flaccid paralysis without fever. What is your diagnosis? Okay. If you have a young adult who comes to you with with combination of upper motor and lower motor neuron lesions, okay, the adult has spastic paralysis. Okay, good. It's AML. Okay. Next one is if you have a patient who comes to you with a history of stroke. Okay, the patient has a history of stroke. Now the patient has loss of pain and temperature sensations below the lesion, loss of upper motor neuron lesion, loss of upper motor neurons, innervation below the lesions. Okay, and there's a lower motor neuron lesion at the level of the lesion of the spinal cord. Burn. Okay, it's not Bernard. Okay, Bernard Soulier syndrome is absolutely something else. It's Brown Sequard syndrome. Brown Sequard syndrome. Okay, what is Bernard Soulier syndrome, please? What is Bernard Soulier syndrome? What is Bernard Soulier syndrome? There we go. Okay. Next one is if you have a patient who comes to you with a history of a sexual transmitted infection. Now the patient has loss of vibration, proprioception, fine touch, tactile sensation. What is your diagnosis? Okay. Now, if you have a patient who comes to you with the same signs symptoms, but along with that, the patient has bilateral loss of pain, temperature, sensation, and ataxia. What is your diagnosis? Okay. If you have a patient who comes to you with a history of weightlifting, now the patient has and bowel and bladder continence, incontinence. Okay. The patient has radicular pain. Okay, good. Okay. Okay. So next one is if you have a patient who has come to you with staggering gait, the patient has dysarthria, patient has diabetes, hypertrophic cardiomyopathy, scoliosis. Okay, what is the trinucleotide repeat disorder? What is the trinucleotide repeat disorder? GAA. What is the chromosome number on which the repeat disorder is taking place? Okay. What is the protein that is defected? Which protein is defected? Okay. What is the cause? What is the function of that protein? Okay, good. Okay. If you have a patient where you see that the patient has suffered from a stroke and there's a jaw deviation, the jaw has deviated to the right side. What is the lesion? Jaw deviation to the right side. Which side is the lesion? Does the jaw deviate? Okay, good. So that's a right sided lesion. Very good. Okay. If you have a patient where the uvula has deviated, okay, where the uvula has deviated towards the left side, which side is the lesion? Okay. If you have a patient who has come to you where the patient's left-sided shoulder is drooped and the patient's head is turned to the right side, which one is the lesion? Okay, good. And what if the tongue deviates to the right side? Which side has the lesion? Okay. Okay, good. Okay. Okay. Now you have a patient who has come to you with headache. The patient has hearing loss, vertigo. Patient has tinnitus. Okay. What is your diagnosis? Okay. Okay. If this is Meniere's disease, what do you guys mean by Menetrier's disease? Menetrier's disease. Let's see who remembers Menetrier's disease. What is Menetrier's disease? Gastric hypertrophy. Very good. Okay. What are the signs symptoms of Menetrier's disease? Very good. Edema, ulcer. Keep in mind, we're not talking about Meniere's disease. We're talking about Menetrier's disease. Meniere's disease is for headache, vertigo, tinnitus. Menetrier's disease is for the stomach overgrowth or gastric mucosa. Okay, good. Okay, so that's what it is. Okay, and having said that, you guys, okay, so when you guys did questions about this from yesterday, did you guys find the questions in common? Okay, good. Okay, so today we are going to start with ophthalmology. Okay, today we're going to start with ophthalmology, and as per promised, hopefully we will finish ophthalmology by today, and we will move forward with the pharmacology portion of neurology. Okay, with that being said, okay, they are too little about autology. Meaning, is the are you talking about the first aid information? Is it less? Do you guys need more information regarding autology? Some more questions from autology or less questions from autology? More or less, because okay, okay. So next time you guys face a question about autology, okay, if you guys face more questions about autology, okay, what we can do is we can take another separate lecture. We can try to break down every details. Okay, that's what we can do regarding autology. Is that something you guys would be interested in? Okay. Okay, good. So how about for today we can let's finish neurology, and then later we can focus a little bit more on autology. How about that? Okay, good. Okay, perfect. You had a question about syringomyelia. Adding in question was it lower extremities, weakness in lower extremities, and kyphoscoliosis. Okay, so if the syringomyelia, if this keeps on increasing, if there's an increase in serines, will they innervate? I mean, will they disrupt the upper motor corticospinal tracts? Yes or no? Yes. No. No, because I told you that the serines will keep on expanding. The serines will keep on expanding, and if the serines keep on expanding, they will keep on. Okay, so let's let's talk a little bit about this. Okay, can you guys see my screen over here? One second. Okay, one second. Okay, so can you guys see my screen? So can you guys see my screen? Okay, good. Okay, so if let's say this is the spinal cord, okay, 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 and this is the serines over here, okay, okay. Now the thing is, if the serines keep on expanding, let's say it keeps on getting bigger, okay, it keeps on getting bigger. If the serine keeps on getting bigger, it can keep on innervating the whole spinal cord. So all the tracts over here can undergo degeneration. We know that the corticospinal tracts are over here, the lateral spinal tracts, they're over here. So the first initial presentation is the cape-like distribution. And then after that, when the serines keep on expanding, then there will be loss of innervations to the muscles, that is the loss of corticospinal tracts. And then eventually it can also go and invade the dorsal column system. Are we clear? Are we clear? Okay. Okay, so that's what it is. Okay. What is your question, please? Where How does stroke cause edema? By that, do you mean vasogenic edema? Vasogenic. Vasogenic edema? Is that what you're talking about? Are you talking about vasogenic edema? Yes or no? Can I get some can I get some answers please so that I can move on? Are you talking about vasogenic edema? Okay, so we are not getting any answer from Dr. Maheshwari. So if you please leave me with an answer, I will explain it how we get vasogenic edema. We talked about vasogenic edema in neurophysiology. We don't mind talking about it again. Having said that, can you guys hear my voice? Okay, so if you guys can hear my voice, Dr. Maheshwari, I asked you about vasogenic edema. If you can say yes or no, then I can explain it to you accordingly. Okay. Having said that, since we are not receiving any answers from her, can we begin with our? Oh, you could not hear anything. Okay, I was asking you about vasogenic edema. It does. Is it? Are you talking about vasogenic edema regarding to stroke? Okay, no problem. Your network got weak. Okay, we all know how that feels. Were you talking about vasogenic edema? Okay, vasogenic and other one. Okay. First of all, let's talk a bit about our revision regarding vasogenic edema. What is vasogenic edema? Vasogenic edema is basically it's defined as an extracellular accumulation of fluid which results from the disruption of blood-brain barrier, right? And extravasations of the serum proteins. So if there is a disruptions of the blood-brain barrier, this could be regarding to meningitis, this could be stroke, okay, this could be trauma, infection, anything which can disrupt the blood-brain barrier can result in leakage of extracellular fluid, and accumulation of the fluid will cause edema. Another one which you are talking about is the edema which occurs due to injury. For example, if there is ischemia or stroke, okay, if there's ischemia, stroke, or for example there is some sort of let's say volume disorder, okay, then what happens is, let's say the brain is surrounded by hypertonic fluid. If the brain is surrounded by hypertonic fluid, will there be cerebral shrinkage or cerebral edema? Fast answers please. If the brain is surrounded by hypertonic fluid, will there be cerebral shrinkage or cerebral edema? For everyone, fast answers please. Shrinkage. That is correct. If the brain is surrounded by hypertonic fluid, there will be cerebral shrinkage. If the brain is surrounded by hypotonic fluid, will there be cerebral edema or cerebral shrinkage? Edema. Good. If the same time, if there is an injury and there is disruptions of the sodium potassium ATPase channel in the cells of the brain, okay, will there be leakage of fluid or will there be swelling of the cells? Will there be cerebral shrinkage or edema, loss of the sodium potassium ATPase? Swelling or shrinkage? Accumulation inside the cells. Okay, so this is very basic knowledge, and I hope you guys understand. Did you guys understand this? Okay. Do we have any more confusions? Okay. There are just some things which we usually skip out, things like this, because these are usually covered in the bachelor's of medicine and bachelor's of surgery knowledge. Okay, but we do not mind revising these things once again. Okay, because we have to keep in mind that the USMLE Step 1 First Aid is an extremely vast book. So we try to go as slow as possible, but it's extremely difficult to talk about every single details. Okay, despite having said that, okay, despite having said that, if you guys need us to answer any questions, we are more than happy to. So thank you, Dr. Maheshwari, for bringing up that question, and hope you got your answer. Okay, so can we move on? begin with our today's lecture? Everyone? Okay, perfect. Perfect, perfect. Okay. So let's start with today's lecture. Okay, for today's lecture, what we are going to do is we are going to start studying about ophthalmology. Okay, we are going to start studying about ophthalmology. Okay. Okay. So that's that. Okay. So right now, what I would be drawing is a very basic diagram. Okay. You guys can help me out. Okay. You guys can tell me what is what. Okay. So the thing is, the first thing that I want to discuss about is before I start drawing the structure for the eye, which I am not going to draw. Okay, I want to know if you guys know all the structures from over here because this is a very basic diagram. Should have been taught to us in our science classes in school. Okay, these structures were taught to us in science classes in school. Are you guys well acquainted with this drawing of the eye? Because this is not the structure I want to talk about. I want to talk about this structure. Okay. Is everyone acquainted with the structures about the eye? About okay. So just a revision, the outer portion is sclera, the middle portion is chorea, I mean choroid, okay. The inner portion is retina, okay. This is fovea, okay. This is the optic discs, okay. Central retinal vein, central retinal artery. You have the optic nerve, anterior segment, posterior segment, okay. Then we have the lens, anterior chamber, pupil, iris, okay. I'm pretty sure you guys know all these structures, okay. So there's no point or problem regarding us discussing this. Okay, the structure that I want to talk to you about is this structure over here because this structure is very important. So this is exactly what you see. Let's say you have an ophthalmoscope. Okay, let's say you have an ophthalmoscope, and in the wards, you go up to a patient. Let's say you want to diagnose an ophthalmological condition. Okay, so you do an ophthalmoscope, and when you do an ophthalmoscope, this is exactly what you see. So what are the structures that you see in an ophthalmoscope? Okay, so first of all, what you see is, okay, you can see certain, okay, so what you can see is, okay, first of all, let me just, okay, first of all, you can see the structure over here, okay, the small structure over here, okay, okay. So this structure over here, okay, this is okay. So what this is this is the physiological cup, okay. So this is the physiological cup, okay, physiological cup, okay, okay. Next one is surrounding the physiological cup, okay, surrounding the physiological cup is another thing over here, okay. What this thing is, what this thing, this disc over here, okay, this disc over here is this disc over here is the optic disc, okay. Okay, so right now we just talked about two things. We talked about the physiological cup, then we talked about the optic disc. Okay, do not worry, we will talk about all these things in details, but it's important for us to know what these structures are because they will help us identify the pathological conditions of the ophthalmology. Okay, so we drew a physiological cup, we drew an optic disc. Okay, the next thing which we are going to draw is another thing over here. Okay, next thing which we are going to draw, another thing over here is, okay, so it's just a very rough presentation. Okay, this part is known as the macula. Okay, this part is known as the macula. Okay, okay, okay. This is known as the macula. Okay, the next thing that I want to draw is Next thing I want to draw is the fovea. Okay, so this whole portion is the macula, and this part is the this part is the fovea. Okay, okay, so this part is the fovea. Okay, okay, so this is the macula. This is the fovea. Okay, next things. Okay, so we are done with all the basic major structures. Now the next things which we have to draw are next things which we have to draw are okay, okay, very easy diagram. Okay, what are these structures? Okay, not octopuses. Okay, they are not octopuses. Okay, what these are basically these are our representation of the retinal artery and the retinal vein. Okay, so when you do an ophthalmoscope, what you see is basically you try to see the shape and size of the optic cup. You try to see the fovea and the macula, and you try to see the retinal artery and the retinal vein. Are we clear? Are we clear about this diagram? Yes or no? Okay. Okay. So if that's what it is, okay. So if that's what it is, so what happens is there are a lot of conditions. Okay, there are certain conditions where what happens is you have certain diseases in which you have okay you have certain diseases in which you have certain problems where these certain structures are disrupted, and these are indications of our these are indications of our problem. Okay. Okay. So right now, the first disease that I want to talk about, we will go into the depth of all the things. So for the first thing being that I want to talk about is, let's say now you have let's say there's first of all, what is the macula, please? What is the macula? Does everyone know the function of macula? Does everyone know this function of macula? What is the function of macula? What is the function of macula, please? Okay. So what does it contain? Okay, good. Okay. Okay. So with as age in as okay, have you guys heard about age related macular degeneration? I'm pretty sure you guys have heard age related macular degeneration, right? So with age, what happens is there's degeneration of the macula. Okay, with age, there's degeneration of the macula. So what you see is with age, what happens is there is okay, with age, what you see is there is degeneration of the macula. Okay, so these parts, so this starts getting degenerated. Okay, so this starts becoming absent. Okay, with age, that's exactly what happens. So with age, this starts becoming absent, and what happens is there are two types of age related macular degeneration. There's a dry type and there's a wet type. Okay, so dry is non-exudative and wet is exudative. Are we clear about that there is a dry type and then there's a wet type? Yes or no? Yes or no? Okay, yes. So everyone said yes. So everyone knows that there is a dry age-related macular degeneration and there is a wet age-related macular degeneration. Okay. In the dry age-related macular degeneration, if you do an ophthalmoscope, first of all, you will see that the macula is not there or there's degenerating. At the same time, what you can see is you can see the the presence of okay, you can see the presence of these small spots over here. Okay, these small spots over here. So the macula has degenerated and we have these small spots over here. What are these small spots? These small spots are known as drusen. These small spots are known as drusen. Okay, Drusen. Drusen spots. Okay, are we clear? Are we clear? Yes or no? So two things that have changed, that has changed in dry age-related macular degeneration. What are the two things? First of all, macular degeneration, and the second one is drusen spot. Okay, are we clear? Can I get some yes? Can I get some no's, please, so that I know we have understood or we have not understood? Thank you so much. Okay, thank you for letting me know. Okay, so that's that. Okay, so what is the first problem? The first problem is age-related macular degeneration. So degeneration of the macula, followed by deposits of drusen. Okay, followed by deposits of drusen. Okay, so this is the problem with age-related macular degeneration. Okay, that's that. There's another type of age-related macular degeneration that is wet. Okay, wet or exudative type of age-related macular degeneration. Okay, and we would be coming to that in in a bit. Okay, so that's that. Okay, so our first change in this one is our first change in this one. This is our normal one, and then our first change was macular degeneration. Okay, let's move on to the next pathology. Okay, the next pathology that we want to move on is okay. The next pathology that we want to move on is so okay. So first of all, is this is the macula, right? This is the macula. Okay, if you see that the macula has now become edematous, okay, so the macula has become edematous. Okay, one second, edematous macula. Okay, so the macula has become edematous. Okay, and along with this, edema of the macula, followed by, okay, edema of the macula, followed by seepage of fluids. Okay, so for fluids, I'm going to give this, okay, seepage of fluids. Okay, so fluids are leaking out of the blood vessels. Okay, so macular edema and fluid leakage. Okay, macular edema and fluid leakage. So fluids are leaking out of the vessels. Okay, can you guys name this condition, please? Does anyone have any idea what this condition is? Macular edema and leakage of fluid. What is this condition? Papilloedema. No, unfortunately, papilloedema is not the right answer, but thank you so much for trying. Does anyone have any other idea? Okay. In which condition do you have hyaline arteriosclerosis of the blood vessels and the blood vessels get weak and hypertension? Okay. Another condition in which there is leakage of the blood vessels due to another condition, DM. Okay. So this is your picture for diabetic retinopathy. Are we clear? This is your picture for diabetic retinopathy. Are we clear? Okay. So what was the first change in the ophthalmoscope that we talked about? What was the first change in ophthalmoscope that we talked about? What was the first change? Age-related macular degeneration. Very good. What were the two things that we saw? Fast answers, please. Fast answers. What were the two things that we saw? First of all, we saw macular degeneration, and then the second thing that we saw was what was drusen spots. Very good, Dr. Gianni. Okay, very good. So that was drusen spots. Okay, then the next thing that we saw was diabetic retinopathy. And in diabetic retinopathy, what are the two changes that we see in ophthalmoscope? Fast answers, please. Fast answers, please. Macular edema and seepage of fluid or leakage of fluid. Okay, thank you, Dr. Hassan. That's what it is. Okay, so that is diabetic retinopathy. Okay, next one. Next one, which we are going to talk about. Okay, okay. So next one which we are going to talk about is, so there is okay, okay. So there are multiple things that are happening over here. Okay, okay. So first of all, okay. So what's happening over here is you have, okay. This is the next disorder. Okay, this is the next disorder. So we have these spots over here. Okay, for these spots, what I'm going to do is, one second. Okay, so we have these spots in the eyes. Okay, we have these spots in the eyes. Okay, okay, so we have these spots, and then what we have is we have this area of exudation. Okay, everything else is a more or less okay, but we have these two things over here. Okay, so this is then ophthalmoscope. Okay, there are some spots over here that is close to the artery. Okay, and then what else? And then what else? And there's another thing that we have is we have exudates over here. Okay, and then we have exudation. And what we also have is we also have some degree of macular edema. Some degree, not a lot. We have some degree of macular edema. Okay, so right now, if I tell you that these are, okay, I'm taking my time over here. Okay, these are our cotton wool spots, and this is exudation. Okay, what is the diagnosis? Okay, even before I can finish my drawing, Dr. Hussam, okay, Dr. Iman, Dr. Naud. Okay, so what the diagnosis is? Hypertensive retinopathy. Very good. Okay, the hypertensive retinopathy. What happens in hypertensive retinopathy is you have uncontrolled hypertension. For this uncontrolled hypertension, what you have is you have damage of the walls of the blood vessels of such as retinal artery and vein, and then there's leakage of fluid, and this leakage of fluid around the blood vessels. This results in the formation of spots known as cotton wool spots. Okay, and what you get is you also get papilloedema. I mean, and then meaning that with hypertension, the intraocular pressure also increase. Okay, along with that, what you also have is you have an area of exudation. I'm sorry, exudation. Okay, so this is hypertensive retinopathy. Okay, so once again, if you see an ophthalmoscope and you see macular degeneration and presence of spots in the middle. Presence of spots in the middle. What is your diagnosis? Well, what is your diagnosis? Drusen or dry age-related macular degeneration. Very good. Okay, next one. Next one is if you do an ophthalmoscope and you see macular edema and seepage of fluid from the surrounding blood vessels. Okay, what is your diagnosis? Diabetic retinopathy. Very good. Next one is if you see retinal hemorrhage, then you see then you see exudation. Okay, then you see cotton wool spots. Well, what is your diagnosis? Hypertensive retinopathy. Okay, hypertensive retinopathy. Okay, next one. Okay, next one. So far so good. Okay, next one is, one second. Okay, okay. Next one. Next one is when you do an ophthalmoscope. Okay, when you do an ophthalmoscope, okay, what you see is, okay, what you see is you see thickness and engorgements. Okay, if you do an ophthalmoscope, you see thickness and engorgement of these vessels. Okay, you see thickness, you see engorgement of these vessels over here. Okay, okay. Along with that, along with that, you have some amount of macular degenerations. Okay, man, the macula is still somewhat there, not there. Okay, and the overlying area over here is uh, is also a bit red. Okay, okay. So if you have these type of thickness of or thickening of the blood vessels, okay, especially the vein, what is your diagnosis? Venal occlusion. Okay, venous occlusion. So this is your ophthalmoscope for retinal vein occlusion. Okay, this is your diagnosis for retinal vein occlusion. Okay, so what do you see? You see that there is retinal vein occlusion. Okay, okay, very good. So this is not that hard to realize that why will there be engorgement and why will there be dilatations of the veins inside the ophthalmoscope? Okay, the diagnosis is retinal vein occlusion. So that's what it is. I mean, if there was proper uh, drainage or no occlusion, okay, there is no need for these veins and these blood vessels to get dilated. So your diagnosis is retinal vein occlusion. Okay, very good. Okay, next one is, okay, next one is, okay, okay. So the next one is our most, this is also sort of high yield. Okay, so for this one, what happens is you see an area over here. Okay, okay, so for all the students, Dr. Hossam, Dr. Ibrahim, Dr. Khatun, Dr. Ahmed, Dr. Dalia, Dr. Nikki, Dr. Gianni, everyone who is answering, Dr. Iman, are you guys answering from your knowledge or are you guys looking at the book and then making your answers? Okay, don't look at the book. Okay, no, don't look at the book. Don't look at the book. That defeats the whole purpose. Okay, that defeats the whole point. Okay, maybe I should have told you guys it's my mistake, it's not your mistake. Okay, do not look at the book and make the diagnosis. Okay, try to think about the pathology behind the diagnosis, and then later we will read the book together, so then we can understand everything from the book. Okay, right now try to understand why these things are happening. And these are some of the most high yield drawings for your UWorld. Okay, if you can master these drawings, then no one can stop you in your ophthalmology questions. Okay, so that's what it is. So thank you for letting me know that you're looking at the book. Okay, so please don't look at the book. Try to answer from your knowledge. Okay, good. Next one. Next one is, okay, next one is, okay, so right now for this patient, when you do an ophthalmoscope, what you see is you see this area of separation of the neurosensory layer. Okay, you see this area of separation of the neurosensory layer. Okay, and okay, so that's what it is. So you see this area of separations of the neurosensory layer. Okay, okay, and along with this, what you see is okay that your patient has vision loss. Okay, that your patient has loss of vision. Okay, and the patient could have a history of diabetes. The patient could have a history of diabetes, and this is crinkling of the renal tissue. And at the same time, what happens is over here, what you can see is okay. So this is what we are focusing on. Okay, this area of the retina which has come off. Okay, what is the name of this diagnosis? Okay, retinal detachment. Okay, this is retinal detachment. Okay, this is known as retinal detachment. Okay, so the purpose of our drawings is just so that we can get well acquainted with these conditions. Okay, the purpose of our drawings is so that we can get well acquainted with these conditions. Okay, so that it won't be an issue for us when we read the diagram. Okay, okay. Next one. Next one is next one is if you next one is a very easy one. Okay, the next one is a very easy one. Okay, so before we move on to the next one, do you guys want to do a quick revision of all the ones that we just discussed? Yes, so that we don't get confused. Okay, so we don't get confused. Okay, so we are all on the right spot. The first thing, what was the first thing that I talked about? The first thing that I talked about was if you have, let's say, if you have, okay, very quick, if you have macular degeneration, okay, so macula has degenerated, and you have these small spots over here. Okay, what is your diagnosis, please? Can you please unmute yourself and let me know so that I don't have to go back to the chat box? What is your diagnosis? Fast answers, please.
Intramacular regeneration.
Age-related macular degeneration.
Very good. Okay, so this is your diagnosis for age-related macular degeneration. Okay, okay. Next one. Next one is if you have a patient. Okay, if you have a patient where what's happening, you have macular edema. Okay, you have macular edema, and then you have seepage of fluid. Well, what is your diagnosis?
Diabetes retinopathy.
Diabetic retinopathy. Okay, very good. Okay, next one. Next one is if you have a patient who has um, these types of these types of spots and an area of exudation. So these are cotton wool spots and an area of exudation. What is your diagnosis?
Hypertensive
Hypertensive
retinopathy.
retinopathy.
Very good. Okay. Okay. Is everyone understanding?
Yes.
Is everyone understanding the diagrams? Why are these things happening? We will talk about them. We will talk about the pathology behind the diagram. No problem. But for now, let's just get acquainted or let's just understand or learn what's happening so that it's easier for us because
مصطفى تعالى افتح لك العصير تعال.
okay. So what we are going to do is we are going to mute you guys and then we will use the chat box. Okay, no problem. Okay. Okay, so we will use the chat box. Okay, no problem. Chat box is better. Okay, next one. Okay. Gotcha. Okay, okay. This one. What is your diagnosis? Okay, please use the chat box to give your answers. Okay. What is diagnosis? Retinal vein. The baby wants juice. Oh, okay, great. Okay, good, very good. Okay, please give the little baby juice and our love and prayers. Okay, our love and prayers are with your little baby. Okay, okay, good. Okay, so that is retinal vein occlusion. Okay, next one. Next one is what is this thing over here? What is this one? Retinal detachment. Okay. So far, have you guys understood all the differentials, all the diagnosis? Yes? Okay. Okay. Give me 1 second. Just let me. Okay. Okay. So if you guys have understood this, then can we move on to the next diagrams? Okay. Okay. Okay, so let's move on to the next diagram. Okay, now for the next diagram is very easy. Okay, what we have is all we have is all we have is this spot over here outside. Okay, okay, I'm sorry. Okay, one second. Okay, so instead of the macula and the fovea, okay, okay, all we have is this small spot. Okay, all we have is this small spot. Okay, can you guys tell me the diagnosis? What is this small spot known as? Does this spot look like a cherry? Does this spot look like a cherry? Cherry. Do you guys know what cherries are? Okay, cherries are fruit. Okay, okay, it's not very common from the country where I'm from. Okay, we don't get a lot of cherries back home. Over here, we get a lot of cherries. Okay, so cherry red spot, very good. Cherry red spot. And what is the cause? The cause is central retinal artery occlusion. Okay, can you guys tell me two other causes of cherry red spots? We see them in some system storage, lysozyme storage diseases. Very good. Tay-Sachs and Niemann-Pick disease. Very good. So central retinal artery occlusion, Tay-Sachs disease, Niemann-Pick disease, and this is your cherry red spot. Okay. Next one. Next one is okay. Next one is a very different type of presentation. Okay. The next one is a very different type. The presentations are like this. Okay. We have the spiky, bony. Okay. You have this spiky, bony type of spicules all around the ophthalmoscope. Okay, you have these spiky, bony spicules all around the ophthalmoscope. Okay. Okay. Do you guys have any idea what this might be? Any idea? It's not retinal degeneration. It's retinitis pigmentosa. Okay, what these are the bone spiculed pigments. So what is this diagnosis? What is the diagnosis? This diagnosis is retinitis pigmentosa. It's very easy. It's extremely easy that the pigments in pigmentosa, these are bone shaped, bone spiculed, and these deposits are known as bone spiculed deposits. Okay, and this is known as retinitis pigmentosa. Okay, retinal degenerations are common, but the thing is, these retinal degenerations are inherited retinal degeneration. These are inherited retinal degenerations. Are we clear about the retinitis pigmentosa? Yes, is everyone clear? Is everyone clear? Okay. Okay, so that's that. Okay, so we're almost close to the end. Okay, we have talked about most of the high yield ophthalmoscopic conditions. Okay, ophthalmoscopic condition. The next one that I want to talk about is last and foremost, we have to focus a little bit about on the optic disc. Okay, so we will focus on the optic disc. Okay, and what if right now I tell you that the optic discs has swollen? Okay, so swelling of the optic disc. Okay, swelling of the optic disc, and there's blurring of margin. Okay, so the optic disc has been swollen. Okay, and the margins have become pretty blurry. Margins of the optic disc have become pretty blurry. Okay, so blurry margin. Okay, so if we have a swelling of optic disc like this, what is your diagnosis? Papilloedema. Very good. Very good. Okay, so it is the type of ophthalmoscopic finding you can expect to find patient with hydrocephalus. Yes or no? Hydrocephalus. Yes. Is this the type of ophthalmoscopic finding you can expect in your patient uh, with an intracranial tumor? Yes or no? Okay, good, good. Okay. So once again, okay, once again, can I give you guys, okay, can I give you guys 1 minute, not 1 minute, 30 seconds. Okay, I will give you guys 30 seconds to look at, okay, so just go through the diagrams, nothing else, nothing else. I want you guys to go through nothing else. Okay, we will we will discuss about all of these right now, but just go through the diagrams, go through these diagrams right now, because the thing is the questions will come from the diagrams, the questions will come from the diagrams, and then you will be asked to make the diagnosis. So we have to perfect and master the diagrams first. So please go through the diagrams first. Okay, for 30 seconds. After 30 seconds, I would need the help of how many volunteers? Two volunteers, okay? Two volunteers who can help me draw the rest of the diagrams and details, okay? So 30 seconds, go through the diagrams and let me know, okay? Please do not, when I ask you the questions, please do not look at the book. Okay, so 30 seconds on the clock. Is anyone done? Because we have to move on. We have a lot of things to discuss. We have a lot of things to discuss. Is anyone done? Is anyone done? Can anyone help me out? Okay. So we have Dr. Iman, Dr. Hussam. Thank you so much. Okay, good. So, okay, do we have anyone else? Okay, okay. So let's start with Dr. Iman. Okay. So, Dr. Iman, would you please tell me what this diagnosis is? Can you hear my
Yeah.
voice?
Yes.
Okay, good. Okay, well, what is this diagnosis?
It macular degeneration, age
Okay,
age related,
okay. Is this dry or wet?
dry. This is
Very good.
drusen spot.
Okay, okay. Next one. Next one is what is this diagnosis? What is this diagnosis?
Diabetes retinopathy,
Diabetic retinopathy,
retinopathy.
macular edema, seepage of fluid from the vessels. Okay, very good. Okay, next one. Next one is um. Okay, next one. Next one is we have these spots and exudation. What is this diagnosis?
Hypertensive retinopathy,
Okay, what is this lesion called?
cotton wool
And this
spot,
one, exudations.
exudate.
Okay, this is exudation. Okay, okay, good. Can we go to the okay? Can we go to the next physician? Okay, next physician was Dr. Hussam. Thank you so much, Dr. Iman, for participating. Can we go to the next physician? Dr. Hussam, would you be kind enough to tell us what is this diagnosis?
Yes, doctor. It's retinal vein occlusion.
Okay, this is retinal vein occlusion. What is this diagnosis?
Retinal detachment.
Okay, what is this occlusion? One second. Okay, what is this diagnosis?
Retinal artery occlusion.
Yes, that is very good. Cherry red spot for
Yeah.
retinal artery occlusion. Okay, and now if you have these types of bony spicules,
Retinitis pigmentosa.
retinitis pigmentosa, very good. And the last one is if you have swelling of the optic disc, then
Papilledema.
papilloedema. Okay, good. So, did everyone understand? Thank you so much, Dr. Hassan, for participating. Did everyone understand the drawings? Okay, okay, good. Uh, So since you guys understood the drawings, okay, let's go to the drawings first and then we can move on to that. So first of all, let's talk a little bit about age-related macular degeneration, okay? So what is age-related macular degeneration? This is degeneration of the macula, okay? And what this does is this causes distortion and loss of central vision. So the central vision is it's lost. And why is the central vision lost? Because if there's macular loss, then loss of central vision, this is known as scotoma, okay? How many types of age-related macular degeneration are there? There are two types, that is dry and then there is wet. Okay. Okay. First of all, put your stars. Okay. How will you get questions from this from UWorld or from the actual exam? You will get questions regarding the diagram. Okay. That's what we just said. And your answer is the diagnosis. Okay. And we have dry and we have wet. And in dry, we have drusen spots. Okay. That is the deposition of yellowish material. Okay. And what happens is this is deposited in the brush membrane. Okay, the this is deposited in between the brush membrane and the retinal pigment epithelium. Okay, so this is another high yield. So please underline this. Okay, where is it present? And it is present in between the brush membrane and the retinal pigment epithelium. Okay, and the progression can be prevented with multivitamins and antioxidants. Okay. Okay. The main important thing about dry age-related macular degeneration uh, is the drusen spots and the diagnosis. Next one is wet or exudative type. Exudative type is rapid vision loss due to bleeding. And what happens is over here you have neovascularization, meaning formation of new blood vessels. And the formation of these new blood vessels, we can treat them with anti-VEGF. Anti-VEGF. Okay. Can you guys name one drug? Oh, okay. The names of the drugs are already over here. Okay, so it's bevacizumab and it's ranibizumab. So that's what it is. So if you have new vascularization, we give anti-vascular endothelial growth factors, anti-VEGF, and the drugs are bevacizumab and ranibizumab. Are we clear about age-related macular degeneration? Okay. How many types of age-related macular degenerations are there? Fast answers, please. Two. What do we see in the dry one? What do we see in the dry one? Drusen spot. What do we see in the wet one? Neovascularization. What drug do we use to treat wet age-related macular degeneration? What drugs do we use to treat wet? Anti-VEGF antibodies. Okay, good. Next one. Next one is diabetic retinopathy. Okay. Next one is diabetic retinopathy. Okay. And there is retinal damage due to chronic hyperglycemia, and we know that. And how many types are there? There are two types, that is proliferative and non-proliferative. Once again, in non-proliferative type, you have leakage of fluid and macular edema. Okay, as we just talked about before, that there was seepage of fluid and macular edema. And how do we treat that? We treat that with blood sugar control. Very easy to understand. But there's another one that is in the proliferative phase. In the proliferative phase, that is due to chronic hypoxia. Okay, what happens is you have with diabetes, what you have is you have damage to the blood vessels, right? And what happens is you have, okay, what you have is in proliferative stage, you also have new blood vessel formation, or or neoangiogenesis. And how do we treat them? We treat them with anti-VEGF. Anti-VEGF. So once again, bevacizumab and ranibizumab. So that's what it is. Anti-VEGF antibodies. Okay. Are we clear about diabetic retinopathy? Okay. How many types are there? No, we cannot find cotton wool spots in diabetic retinopathy. Okay. So we have, okay, we have the proliferative and non-proliferative. Okay. Okay. So what happens in the proliferative phase? What happens in the proliferative phase? Hypoxia and neovascularization. Okay, very good. Next one. Next one is hypertensive retinopathy. And we talked about this. We talked about the fact how you have exudation and cotton wool spots. Okay, so you have retinal damage due to uncontrolled hypertension. As a result, what you have is two big things. First of all, you have an exudate, okay, exudate, and you have these spots, cotton wool spots, okay. You have these cotton wool spots, okay. Okay, so these are the cotton wool spots. And what happens is, if you see that in this patient, the optic disc has gotten bigger, okay, if you see that the optic disc has gotten bigger, then it's a risk because increased amount of optic disc, meaning that there is increase of intracranial pressure. And this is a hypertensive emergent. This is a hypertensive emergency, okay, where the patient can have stroke, coronary artery disease, or kidney diseases. Along with this, you can also see that the patients have arteriovenous nicking. Arteriovenous nicking basically means breaking off of the artery and the venous channels. Microaneurysms, meaning seepage of fluids from the blood vessels over here. I mean, that dilatation of the blood vessels, okay? And you get the macular stars. Macular stars are basically the term used for exudation, so over here. But the retinal hemorrhage, arteriovenous nicking, and microaneurysm is so small that it's impossible to visualize that in the ophthalmoscope. So the main two things that you see are cotton wool spots and you see exudations in hypertensive retinopathy. Are we clear about hypertensive retinopathy? Okay, next one. Next one is easy to understand. It's retinal vein occlusion. If you have a blockage of a retinal vein, either due to atherosclerosis or for any other reasons, what this will do is this will cause engorgement of the veins. This will cause engorgement, okay? And this engorgement is known as the retinal hemorrhage and venous engorgements that we see in retinal vein occlusion. And this is what you see. Do you see that these are engorged, okay? If you see a picture like this, then you have to understand that there is a blood vessel engorgement. And this is what you see in retinal vein occlusion. Once again, are we clear? This is easy to understand. Okay. Will you receive questions? You will receive questions from the diagram, and your answers are the diagnosis. Are we clear? Everyone? Okay. Okay, so for every other student who is not responding, are we clear, Dr. Damilola, Dr. Hassan, Dr. Aldera, Dr. MS, okay? Then Dr. Yusuf, Dr. Dalia, Dr. Jordan, Dr. Uday. Okay, are we all clear? Because if we have any confusion, now is the time. Dr. Evelyn, okay, Dr. Ibrahim, okay, good. I just asked a question. I am so sorry. I missed your question. I'm sorry. Let me just go back and see what the question was. Are pictures exactly as they appear on first aid? Yes. My answer to your question is yes. The pictures are more or less exactly to what they appear on first aid. Okay, I'm so sorry. I did not see your question. Okay, at times when you guys ask questions in the chat box, I miss it. Okay, but please help me out by asking the question again, and I will answer it for you. Okay, next one. Next one is retinal detachment. Okay, So this is the one that we talked about, that how the retina comes off from over here, because this could be the separation. Okay, so the separation is of the neurosensory layer of the retina. Okay, and this comes up from the pigmented epithelium. And what happens is you get degeneration of the photoreceptors. Okay, and degeneration of the photoreceptors, and all of these things are important. But once again, the most important question is the diagram, and the most important answer is the diagnosis. Okay, and how do you see this? This is usually described as crinkling of retinal tissue. So if you do a fundoscopy, okay, what you see is you see crinkling. You see that these parts are crinkled, and they come off, right? And this is what you see in retinal detachment. Okay, okay. And the breaks are more common in myopia and head trauma. So let's say this type of patients can get head traumas or refractive error. Okay, and this can give rise to retinal detachments. Okay, and how will the patient complain of? The patient will complain that the patient has a gradual loss of vision, and the patient feels like there's a curtain drawn appearance. So let's say that this is your vision. Okay, let's say that this is your vision. Okay, if you have retinal vein occlusion, eventually will happen is what will happen is you will feel like this part of your vision is getting lost. This part of your vision is being lost, and this is the only part from where you can see. Okay, so this feels like a curtain drawn appearance, like as if someone put a curtain over your vision. And this is a surgical emergency because the retina is detached. If we don't try to fix it immediately, the patient can have complete blindness. Okay, are we clear? Are we clear? All pictures look similar. All the pictures will not look similar if you keep my description of the diagrams in mind. Okay, if you keep my description of the diagrams in mind, then the pictures are bound to not look similar, to not look similar. Okay, you have to be very careful. That's why I'm taking so much time in making you guys understand each and every problem regarding these ophthalmoscopic pathologies. Okay, okay, good. Next one. Next one is very easy to understand. All you have is this cherry red spot. You can see it over here very clearly. Okay, so this cherry red spot over here, and this cherry red spot once again is your central retinal artery occlusion. Okay, so that's that. And the what is the complaint? The complaint is basically the patient will come to you. They will say that this patient has a sudden onset of painless vision loss. Sudden onset of painless vision loss, and this could either be due to an embolic source. So basically, if you have an emboli which has traveled all the way to the central retinal artery, this will block and the patient will have loss of vision. And I personally know one patient who has had this, and his complaint was literally he was sitting down watching TV. He had no idea, he had absolutely no idea that he was undergoing this type of problem. And what happened was out of nowhere the patient had loss of vision. The patient had out of nowhere the patient experienced loss of vision. Okay, and what happened was the patient had was diagnosed with central retinal artery occlusion. So that's what it was. So the loss of vision is acute, all of a sudden, and completely painless. So that's what it is. Okay, next one. Next one is retinitis pigmentosa. Retinitis pigmentosa, once again, you see this bony spicules over here, as I talked about. Okay, inherited retinal degeneration. Okay, this is the bone spicule shaped lesions, and that's what you see in retinitis pigmentosa. Okay, that's that. Once again, how will the questions appear? Questions will appear with the diagram, and your answer is the diagnosis. Okay. Last one is very easy to understand. As you can see that the optic disc has swollen all the way over here. So the swelling of the optic disc, swelling of the optic disc. Okay, what is the name of this condition? The name of this condition is papilloedema. Where do we find these conditions? These conditions are found in places of increased intracranial pressure. Okay, when the intracranial pressure is increased, either due to hydrocephalus or due to a tumor. So what happens is there's enlargement of the blind spot, right? And this is known as papilloedema. Okay, once again, question diagram, answer diagnosis. Okay, are we clear about all of the lesions? Okay, good. Okay, confident? Are we confident about diagram? Okay. Okay, good. So that's exactly what it is. Okay, so that's exactly what's happening over here. Okay, so with that being said, now we can move on to the previous pathologies. Okay, now we can move on to the previous pathologies and let's start. Okay, now let's start with ophthalmology, and the rest of these things will be extremely easy for us to understand. Okay. Okay, now since we have covered one of the monster topics of ophthalmology, then the rest of the ones are not that difficult, okay? Except the one that we also have to talk about another thing. And another thing that we will talk about is the visual field defects, okay? The visual field defects and the visual field defects, we will talk about them, okay, in a while, in 1 second. And, okay, we also have Horner syndrome and ocular motility. Okay, let's move on. Okay. So the first thing that I want to talk about is this condition called as conjunctivitis. Are we all well accustomed to conjunctivitis? We all know what this is. Okay, conjunctivitis. This is a very normal and a very usual thing that we all have gone through once or twice in our life. This is basically inflammation of the conjunctiva. So basically a red eye. Okay, so if it's allergic, that means the eyes will be itchy. If it's bacterial, there will be pus, and if there's bacterial, our treatment is with antibiotics. Okay, if it's viral, then the most often cause is adenovirus, and this is high yield. Okay, the most common virus for conjunctivitis is adenovirus. Okay, and what you can see with adenovirus is you can also see that there's swelling of the preauricular nodes. Is that you can also see that there's swelling of the preauricular node. And the good news is if it's a viral conjunctivitis, then it's extremely contagious, but it is self-resolving. Okay, okay, so I'm pretty sure you guys have understood exactly what um, conjunctivitis is. Okay, next one are your refractive errors. Okay, what are the refractive errors? Refractive errors are the reasons why we wear glasses, right? So refractive errors are very easy to understand. They are the most common cause of impaired vision, and they are correctable with glasses. Okay, so first of all, the first refractive error is hyperopia, also called farsightedness. Okay, farsightedness. So if you have hyperopia, okay, if you have hyperopia, do you have a problem looking far, or do you have a problem um, looking at objects that are too far away, or do you have a problem looking at objects that are near? Do you have with hyperopia? Do you have a problem looking at objects that are near, or do you have a problem with objects that are far away? And your answer is near. Okay, so this is farsightedness. Also, this is called farsightedness, but the problem is you have a problem looking at eyes. I mean, looking at objects that are near. So the eyes are too short for the refractive power of cornea and lens, and the light is focused behind the retina. Okay, so once again is okay. Let's say this is your lens. Okay, okay. Once again, okay, let's say this is your lens, this is your retina, okay, this is the object, okay, okay. So what's happening is this light is being focused over here, and this light is being focused over here. Okay, so this is being focused behind the retina, so you cannot see clearly. Okay, you can look far but not near. That is correct. Okay, for far-sightedness, meaning you can look far but not near. Exactly. So this is what's happening. You have the object and the focus is behind. So what you do is you correct it with a convex lens. Okay, so you have a more convex lens. Okay, so the next time what you do is if you add a lens, okay, next time what you do is if you add a lens, that is more convex. Okay, if you had a lens that is more convex, what would happen is this time, the image, instead of being focused over here on the back of the retina, they will get focused over here in front of the retina. Next, the next one is myopia. Myopia means nearsightedness. Okay, if you have myopia, do you have a problem looking at far, or do you have a problem looking at substances or objects near? Far, very good. So you cannot look that far. So nearsightedness, meaning that you can look at you can look at objects that are near to you. Okay, so what's happening with myopia is, so let's say once again, this is your lens, this is the object, this is the retina. Okay, and what's happening is, okay, okay, and the thing is focused over here. And so if this is the retina, then this is the object that is being focused. So it's being focused in front of the retina. So for this one, you need a lens that is more concave. Okay, you need a lens that is more concave like this. Okay, and for this one, you need a lens that is more convex. Okay, the convex lens, you need a more convex type of lens. That's what it is. Have we understood hyperopia and myopia? Yes or no? Okay, now, if you have a patient who has come to you, or you have anyone in your family who comes to you, who tells you that I have a problem looking at things that are very close to me. Okay, I cannot look at the screen, the laptop screen, but I can look at the view of the sunset. Okay, well, what is the diagnosis? Hyperopia or myopia? What is the diagnosis? Hyperopia or myopia. Okay, so the patient has farsightedness, so the diagnosis is hyperopia. Let's see who said myopia. Okay, Dr. Adhanom. Okay, it must have been a mistake, right, Dr. Adhanom? Or did you not understand? Yes, okay, it was a mistake. Okay, so it was hyperopia. Okay, the next one was if you have a patient who comes to you and tells you that I can see things that are very close to me, but what happens is, this usually happens to little students, okay, to little babies in classes. The teacher complains that the patient cannot read what's written on the board. Okay, some of us have. So, do we have? Okay, so that's you. Okay, so Nikki. Okay, so that's okay. So you understand what the problem is. Okay, so what is the treatment with myopia? Convex or concave? Concave. What is the treatment with hyperopia? Convex or concave? Very good. Okay, that's it. Next one is astigmatism. Okay, what is astigmatism? Astigmatism is basically abnormal curvature, meaning that that the lens have different power. I mean, different refractive power at different axes. Okay, so astigmatism. Astigmatism is the abnormal curvature of the cornea. So the cornea is abnormally curved. It's not a problem with the lens. Okay, so due to the abnormal curvature of the cornea, okay, the patient has blurry vision, and the patients has they do not have a specific problem of looking far or looking close, but they have different refractive power, and most of the time they have, if it's a severe form of astigmatism, then they have blurry visions. And the most easy way you can correct it is by cylindrical lens. Okay, with the help of cylindrical lens. Okay, are we clear about the refractive errors? Okay, the most important ones are hyperopia and myopia. Most important one, hyperopia and myopia. Okay, next one. Next one is presbyopia. Well, what is presbyopia? Presbyopia is basically age-related impairment or accommodations. Okay, so what happens is with increase in age, okay, the lens lose their elasticity. As a result, what happens is when they lose their elasticity, there is a change in the lens curvature, and there is decreased strength of the ciliary muscle. Okay, so they can focus easily on near objects. So they can focus easily on near objects. So if you have a patient with, so if you have a patient, okay, so now they can see near objects. So if the patient had hyperopia, okay, if the patient had hyperopia, so with increased age, is there a possibility that the eyes can get fixed? Yes or no? Improve. Okay, why? Why will the eyes get improved if the patient had hyperopia? Okay, why will the eyes get improved? I mean, nearsightedness. No, they can already see things that are near. Okay, they cannot. Okay, they can focus more on. They can focus on near objects. Okay. Okay, so we're getting a lot of different types of responses. We're getting cataracts, myopia, farsightedness. Okay. Okay. First of all, if the patient can see, if the patient has the ability to focus on near objects, okay, because there's decrease in lens elasticity and change in lens curvature, which type of refractive error can the patient have fixed? Which type of error can the patient fix? Which type of error will be fixed? Anyone? Hyperopia. That's okay. So, Dr. Adhanom, are we clear about this? Do we have any confusion? Yes, patients need reading glasses. Okay. But there could, all I'm talking about is improvement. Will there be improvement of hyperopia with presbyopia? Yes or no? That's all I'm saying. That's all I want to know. Yes. Okay, good. Okay, good. Okay. Have we understood the refractive error? Have we understood all the refractive errors? Yes or no? Okay. Can we move on to cataracts? Okay. Presbyopia is the ability. Okay. Oh, why do patients need reading glasses even if hyperopia is corrected? Hyperopia is not 100% corrected. There is improvement. That's all I'm trying to say. Okay. Okay. There is improvement. There is not 100% correction of hyperopia. Okay. And the reason why I'm asking you this is if okay, the reason I'm asking you this it's because the reason why I'm asking you this is because you will get questions about this in MBOS, that what type of refractive error is corrected with presbyopia. Okay, is it hyperopia or is it myopia? That is the question. Okay, what is the improvement? The improvement is decrease in lens elasticity and lens curvature and decreased strength of the ciliary muscle. That is the improvement. Okay, this helps improve the hyperopia, but the patients will still need reading glasses. Okay. In myopia, what happens? Okay, you didn't. Okay, okay. So the thing is, since it's confusing you guys, okay, you do not have to focus on this. So please do not focus on this. Okay, first and foremost, have you guys understood hyperopia, myopia, and presbyopia? Yes or no? Okay. If you have understood that, then that's enough. Okay, I do not want to put extra information and then confuse everything. Okay, if you have understood that, then that's enough. There's nothing more you have to understand. Okay, good. Okay, next one that I want to talk about is cataract. Okay, next one I want to talk about is cataract. So what is cataract? Cataract is basically painless bilateral opacification. Okay, okay. So cataract is basically painless bilateral opacification of lens. Okay, and this results in glare and decrease of vision. Okay, as you can see over here that this patient has the cataract, and the risk factors are acquired risk factors, that is with increase of age, smoking, and alcohol use. Okay, and the most important cause is prolonged steroid use, diabetes mellitus, okay, and some infective causes, for example, in little babies, okay, in babies who have trisomies 13, 18, and 21, okay, galactosemia, galactokinase deficiency. We will talk about these things in biochemistry, no problem, okay, and in infections such as torch infections, okay. What are the torch organisms, please? What are the torch organisms? Toxoplasma, then Toxoplasma, rubella, cytomegalovirus, and H4, H4 herpes, and torches. So also syphilis to some extent. So torch infections. And then you have Marfan syndrome, okay, Alport syndrome, and myotonic dystrophy, neurofibromatosis type 2. Okay. Do you have to remember all the causes of cataract? My answer is no. Okay, you do not have to remember all the causes of cataract. Okay, okay. The questions that will come from cataract are just the ones that are associated with steroid use. Okay, USMLE has questions. UWorlds basically has questions where they would like to know that if you know that long-term steroid use can lead to formation of cataract. Okay, okay. If you have a patient with cataract, what is the treatment? What is the treatment? Surgery. Okay, very good. Okay, so treatment is surgery. As simple as that. Okay, good. Very good. Okay. If you have a patient with refractive error and the patient wants to have a surgery, what is the name of that surgery? Anyone? LASIK. Very good. What is LASIK? Laser associated in situ keratomaliosis. Okay, let me write it down. Why am I writing it down? Okay, why am I writing this down? Why is this important? This is important because this is a question in MBOS. Laser associated in situ keratomaliosis, if I'm not wrong. Okay, so if you ever come across a question where they use a broad spectrum term that is laser associated in situ keratomaliosis, I do not want you guys to get scared and afraid and intimidated. Okay, all they're talking about is LASIK. LASIK is the surgery that we use for the treatment of the refractive errors. Are we clear? Yes or no? Okay, okay. Do you guys want to write this down in your book just in case? Yes or no? Okay, done. Okay, good. So that's what it is. Okay, next one. Next thing that I want to talk about is the aqueous humor pathway, and then I want to talk about glaucoma. Okay. Okay. So the aqueous humor pathway, we all know what the pathway of the aqueous humor is. Okay. So the aqueous humor forms and the aqueous humor drains. Okay. So first of all, who produces the aqueous humor? Okay. First of all, let's talk about the production and then the drainage. So I could have drawn an extra diagram, but that would have killed us time. So let's just use this diagram to understand what's going on over here. Okay. So the aqueous humor, first of all, it is produced by the non-pigment epithelium on ciliary body. So this is the ciliary body over here, and this ciliary body has pigmented and non-pigmented epithelium. So for this non-pigmented epithelium over here, they produce this substance known as aqueous humor, and they secrete this aqueous humor. Okay, so what's happening is this aqueous humor, this is secreted, After this is secreted from the non-pigmented epithelium of the ciliary body, this goes through the posterior chamber. Through the posterior chamber, it goes in front of the lens. In front of the lens, what they do is they go in front to the anterior chamber through the trabecular meshwork, and then they come over here and they stay over here as aqueous humor, okay, which provides another which is important for the support and providing nutrition to the structures such as the lens and the cilia, and they are also used as a refractive medium, okay. And then after they are produced, they have to be drained, okay. So for their drainage, there are two types of flow. First flow is uvoscleral outflow, which is around 10%, which is not that common. The most common one is trabecular outflow, which is 90%. Okay, so the trabecular flow that goes through the canal of Schlemm. Okay, as you can see that the canal of Schlemm is over here, and they drain through the trabecular meshwork into the canal of Schlemm, and then they're taken up into the vasculature. What is the name of the vasculature? Episcleral vasculature. Episcleral vasculature. Okay, and the one that goes through the sclera, to the uvoscleral outflow, they drain into the uvea and the scleral space, and this increases with increase in prostaglandin agonists. Okay, so first of all, once again, aqueous humor pathway. Who produces aqueous humor? Uh, Fast question, fast answers, please. Who produces aqueous humor? I'm pretty sure you guys know. You guys have learned about this in your previous knowledge. Ciliary body. Which cells of the ciliary body pigmented or not pigmented? Fast answers, please. Non-pigmented. From the ciliary body, where does it go? The anterior chamber, the posterior chamber at first. Posterior chamber. From the posterior chamber to the anterior chamber. From the anterior chamber, which pathways through which it drains? Which two pathways are used for their drainage? Fast answers, please. Trabecular outflow, uvoscleral. Which one is the most common outflow? Trabecular outflow. How? What is the percentage? What is the percentage of the trabecular? 9%. And then goes to the uvoscleral is 10%. Now, if we have to, okay, so if we have to decrease the production of aqueous humor, in which condition is there is increased aqueous humor problem? What is the name of the pathological condition in which increase of aqueous humor is the problem? And it's provided by Dr. Hassan is glaucoma. That's glaucoma is exactly correct. Okay, so in glaucoma, what you want is you want to have decreased productions of the aqueous humor. Okay, so this is produced by the non-pigmented epithelium on the ciliary body. Okay, and the way that you can decrease the production of the aqueous humor is by alpha 2, okay, and beta blocker. Alpha 2, beta blocker, and carbonic anhydrase inhibitor. How extremely convenient that the names are A, B, and C. Okay, I find this extremely convenient because this helps us remember. Okay, alpha 2. Okay, another thing is, once just to test your knowledge about autonomic drugs, alpha 2, does it increase sympathetic or decrease sympathetic activity? Very good. Okay. This decreases sympathetic activity. Okay, so every one of us know that alpha 2 decreases sympathetic activity. Okay, so you guys are much better than the previous answers I got from my previous students. Okay, okay. So alpha 2 agonists, that's what it is. So alpha 2 agonists are alpha, beta, and carbonic anhydrase inhibitors. Next one is trabecular outflow. Trabecular outflow is okay. How can we increase the trabecular outflow? The trabecular outflow is increased with the help of M3 agonists. Okay, and uvoscleral outflow are with prostaglandins. Okay, okay. So trap the mouse. Trap the mouse. Trap the mouse for trabecular outflow, which is used for M3 agonists and Go, go up. UP. Okay, go up. Go up. UP for uvoscleral outflow that is used, that is increased with the help of prostaglandin agonists. Okay, prostaglandin agonist. So, what are the three mnemonics that we used? First of all, what are the drugs that is used for decreasing the production of aqueous humor? Fast answers, please. What are the drugs used for decreasing the production? Okay, very good. ABC. What are your ABCs? Fast answers. What are your ABCs? Fast answers. Alpha, beta, carbonic anhydrase inhibitors. Next one. Next one is how can you increase the trabecular outflow? How can you increase the trabecular outflow? M3. What is the mnemonic? What is the mnemonic? What is the mnemonic? Trap the mouse. Okay, very good. Trap the mouse. And then how can you increase the uvoscleral outflow? Go up. Okay, for prostaglandin. Okay, okay. Can you guys just give me 1 minute, please? Okay. Can you guys hear can you guys hear my voice? I'm sorry for that small inconvenience. Okay. Okay, good. So the first thing that we talked about was, first of all, what was that? First of all, we talked about decreased production of aqueous humor. That's by ABC. Then trap the mouse, increased trabecular outflow by M3 agonists, and then go up for uvoscleral pathway that is increased with the help of prostaglandin agonist. Okay. Are we clear about the aqueous humor drainage and the mouse? Trap the mouse meaning that that's the mnemonic that we use for the fact that M3 agonists are used to increase the trabecular outflow. Okay, are we clear? Can I get some fast response so that I can either move on or do things? Okay, thank you so much. So if everything is cleared, do you guys want to take a small break before we begin because it's already been 2 hours, or you want to keep on continuing because I feel like you guys are taking you guys are a little bit tired, okay, and a little bit exhausted all the diagrams of the ophthalmology. Okay, so would a break help? Yes or no? How long do you guys want to take the break, Doctor? We need to dig deep for treatment of those. Okay. So, Dr. Naud, what is your question, please? Do we need to dig deep for treatment of those 8 previous pathology, example of venous occlusion? So are you asking about the treatments of the pathology which we have just discussed? Yes or no? Can I get some fast response, Dr. Nood? Okay, so what are you asking? The previous pick. This picture, the pathology is regarding this picture. Which
No,
picture?
my
Yes.
question is, are we supposed to know each and every treatment, for example, the hypertensive retinopathy, retinal vein occlusion, the previous aid or
Okay. Okay. Thank you for asking the question. So first of all, let's see over here. The treatments that are important for you to know are the ones I have already talked about. That is VEGF for age-related macular degeneration. Okay, wet one. Okay, because this is asked in the question. That's number one. For diabetes, we know what the treatment is, the control of diabetes, and then once again, you have anti-VEGF, and anti-VEGF is very important for your treatments of diabetic retinopathy and age-related macular degeneration. Next one is the treatment for hypertensive retinopathy. It's very easy to understand that the treatment is antihypertensive. Retinal vein occlusions, they won't really ask you for any treatments. And retinal detachment, the treatment is surgery. Central retinal vein occlusion is atherosclerosis, so there is no treatment. And for retinitis pigmentosa, once again, the treatments are not that high yield. Okay, for papilloedema, okay, the treatment is a surgical intervention or with medical treatments such as acetylzolamide or carbonic anhydrase inhibitors. So the thing is, the treatments which I have just said are the only treatments that are important for your purpose of doing good in step one. But if you want to dig deeper into the treatment, that's important more for your step two. Is that clear? Okay. Thank you for asking that question. Do we have any more questions from anyone else? Anyone else? Do we have any more questions? Okay, so I suppose we have no more questions. So it's 11:15 as of right now. Okay, so should we take the break right now? Yes or no? Okay. Okay, so we will take the break for 10 minutes and then we will come back. Okay. Thank you. That's exactly what I was going to do right now. Okay, that's exactly what I was going to do. I was going to charge my laptop. I could not wait because this was ending and I was getting a bit anxious. Thank you, Dr. Node, for letting me know. Okay. Okay, can everyone hear my voice? Okay, can everyone hear my voice? Everyone, is everyone back from the break? Can you guys hear my voice? Is this everyone back? Okay. So how are you guys finding ophthalmology? Difficult or not difficult? Not difficult. That is good. Okay. Did you guys the most important questions from ophthalmology are from the visual field defects, which we will talk right now um, in a while. Okay. And another thing about ophthalmology is another thing about ophthalmology is thank you so much for saying that, Dr. Iman. Okay. Another thing about ophthalmology is the ophthalmoscopic findings. Okay, the ophthalmoscopic findings. That's it. Okay. So should we begin? Should we begin? Okay. So the next thing I want to discuss before we move forward. Okay, let's finish glaucoma real quick so that we can move on to visual field defects. Okay. Let's finish glaucoma real quick so that we can move on to visual field defects. Okay. So first of all, what is glaucoma? Glaucoma is basically optic disc atrophy with characteristic cupping. Okay, so this is the normal optic disc. So as you can see that the normal optic disc is like this. Okay, and that. Okay, okay. But if this one, where is the image? Okay, so this is the physiological cup. See the physiological cup over here? Okay. The physiological cup you can see over here. Okay, so if this physiological cup, okay, if this gets bigger, okay, if this physiological cup, if this gets bigger, okay, this is known as optic disc cupping. Okay, this is known as cupping of the optic disc. Okay, and what happens is over here you have thinning of the outer rim of the optic nerve head. Okay, and what is the most common problem with glaucoma? The most common problem with glaucoma is your increased and intraocular pressure. So the intraocular pressure increases, and there's progressive visual loss. And the visual loss is progressive. It's not an acute loss; it's a progressive loss, and it's a progressive loss. Okay. And how do you treat glaucoma? Do you treat glaucoma by either by a medical approach, okay, by the drugs we just talked about, or we can have a surgical approach of glaucoma. So this is important. Okay, this is high yield. Okay, and the fact that you can diagnose glaucoma via an ophthalmoscope if you see cupping, this is important. Have you guys understood? Okay, next one. Okay, how many types of glaucoma do we have? Do we have two types of glaucoma? One is open angle and closed angle. Open angle glaucoma is when the angle is open, meaning that there is no problem with the drainage. It's usually painless and it's very common in US. Okay, and the primary cause is unknown, but the secondary cause is since the angle is open, there should be one problem. The problem is with the trabecular meshwork blockage. There could be a blockage of the trabecular meshwork, and we know that the trabecular meshwork is important for 90% drainage of the aqueous humor. Okay, and when can this get blocked? This can get blocked by fibrosis from chronic inflammation, such as uveitis. There could be vitreous hemorrhage or retinal detachment. So these are the three causes. Well, what are the three causes? Fibrosis, hemorrhage, and retinal detachment. So these are the three causes of open angle glaucoma. And open angle glaucoma is one of the most important cause of glaucoma in US. Okay, next one. Next one is closed angle glaucoma. I'm pretty sure you guys know what closed angle glaucoma is. That's basically, as you can see in this picture, that the angle over here is closed. Okay, and this is the enlargement of the anterior movement of the lungs. I mean the lens against the central iris. Okay, as a result, what happens is since there's anterior movement of the lens against the iris, against the central iris, this closes the pathway for the drainage of the aqueous fluid. As a result, the fluid builds up, and the fluid pushes the iris against the retina, against the cornea. So is closed angle glaucoma or narrow angle glaucoma painful or not painful? Is it painful or not painful? It's actually painful. Okay, so it's very painful. Okay, and this is the primary cause. And what is the secondary cause? The secondary cause is hypoxia. As a result, what happens is when we get hypoxia, for example, in diabetes or venous occlusion, we have vasoproliferation or neoangiogenesis, which we try to stop with anti-VEGF, right? We talked about that, how we use anti-VEGF, that is bevacizumab or ranibizumab. Okay, we use anti-VEGFs, bevacizumab or ranibizumab, and we try to prevent that neovascularization. So we do that, and we try to prevent the secondary cause by preventing neovascularization. But the secondary cause is due to neovascularization from hypoxia. Okay. Now, if we have acute closure, for example, if the angle closes very acutely, the intraocular pressure will move the iris forward, and this will result in a very painful red eye and sudden loss of vision. Along with this, the patients will have halos around lights. Okay, the patients will have halos around lights. Okay, okay. Can we see an image of halos around lights? Okay, this is this is what you can. This is your vision. Okay, this is what you will see. Okay, this is exactly what you will see if you have an acute onset of narrow angle glaucoma. That is halo. Okay, you will see a halo around light. Okay, okay, and then you will get frontal headaches and dilated pupil, along with that, nausea and vomiting. And the agents that you should avoid are mydriatics. What are mydriatics? Pupillary dilators or pupillary constrictors. Mydriatics, pupillary dilators or pupillary constrictors. Dilators. Okay, so if you dilate the pupil, okay, mydriasis, meaning pupillary dilatations. If you dilate the pupil, will this close the angle more or open the angle? Will it close the angle or open the angle? The angle. Will it increase the narrow angle glaucoma or decrease the narrow angle glaucoma? Increase the angle glaucoma. So will it be more painful or less painful? More painful. Yeah. Be more painful. So you should avoid mydriatics. You should avoid mydriatics. Okay. Okay. Have you guys understood open angle, closed angle glaucoma? Once again, the cause of open angle glaucoma. What is the primary cause is idiopathic. What is the secondary cause of open angle glaucoma? What is the secondary cause of angle glaucoma? Fibrosis, then trabecular blockage, retinal detachment, and vitreous hemorrhage. What is the cause of narrow angle glaucoma? What is the cause of narrow angle glaucoma? Narrow angle glaucoma. Anteriorly moving lens. Okay, hypoxia. Okay, good. And what drugs should we avoid in narrow angle glaucoma? Okay. Next one is uveitis. Okay. Next one is uveitis. Okay. Next one is uveitis. Uveitis is basically inflammation of the uvea, specific name based on location within the affected eye. Okay. So we have the uvea which is affected, and if you have a patient with uveitis, okay, you didn't get acute closure. Okay, acute closure is basically narrow angle closure. Okay, narrow angle, meaning that the angle of over here through which the aqueous humor drains, we need a good amount of angle. We need a proper wide angle or a proper normal angle for the aqueous humor to go. If right now the lens comes and obstructs this one for Dr. Nikki, will there be more drainage or less drainage of the aqueous humor? Dr. Nikki, will there be more drainage, less drainage? Less drainage. If there is less drainage, so will the intraocular pressure be increased or decreased? Dr. Nikki, will the intraocular, if it's increased, will there be more pain or less pain? More pain. Okay, and this is the cause of narrow angle glaucoma. Have you understood? Okay, okay. Okay, so next one is uveitis. Uveitis is basically your inflammation of the uvea. Okay, now my question was, if you have a patient with uveitis, okay, if you have a patient with uveitis, what are the diseases? What are the types of diseases that you should think about? Is uveitis associated with any other disease? Yes or no? Uveitis is associated with a lot of diseases, and systemic diseases are basically rheumatoid arthritis, that is very important. Then HLA-B37 associated condition, that is ankylosing spondylitis, JIA, sarcoidosis, okay, sarcoidosis, and these are some of the things that you have to consider your assembly step 1 if you have a patient with uveitis. Uveitis is basically inflammation of the uvea, anterior uveitis, meaning that the parts of the uvea which are anterior, that is iris, choroid, and that is iris, and then the posterior parts are choroid and retina, so choroiditis and retinitis, and altogether if you have iritis, choroiditis, and retinitis, then you have a whole anterior and posterior uveitis. Okay, basically uvea, anterior uvea consists of the iris, posterior uvea consists of the choroid and the retina, and if you have inflammation of these layers, then you have uveitis. Next one is, what is hypopyon? This is very important. This is a UWorld question. This is a very important UWorld question. What is hypopyon? Basically, the question goes is, you have a patient who comes to you with accumulation of pus in the anterior chamber. What is the term that we use for the accumulation of pus in the anterior chamber? And the term that we use for accumulation of pus in the anterior chamber is hypopyon. Okay, are we clear about hypopyon? Okay, have you guys heard about hypopyon before? Yes or no? Of course, you have heard. Okay. Okay. If you guys have not heard about hypopyon as of yet, have you guys finished your ophthalmology ward duties in the hospital? Okay. If you guys have finished ophthalmology, or you guys will do ophthalmology, okay, please try to find a patient with hypopyon. I'm pretty sure you will find one. Okay, I'm pretty sure you will find one in which you will see that the anterior chamber, okay, so in the anterior chamber, that is in this chamber, there's collection of pus, and this pus is known as hypopyon. So once again, if you have not heard about hypopyon, then you heard about it today. So what is hypopyon? Hypopyon is basically accumulation of pus in the anterior chamber. Okay, so that's what it is. Okay, having said that, have we understood glaucoma and uveitis? Have we understood glaucoma and uveitis? Okay, next important thing is, okay, next one is, let's talk very quickly about what leukocoria is. What is leukocoria? Leukocoria is basically this whitening of the red reflex. This whitening is of this whitening of the eyes, as you can see over here. This is known as leukocoria. This is a very important indicator of an infantile retinoblastoma. Okay, along with this, this can also indicate congenital cataract or toxokeratosis or toxocariasis. Okay, but retinoblastoma is number one. Okay, and this is extremely high yield. Okay, if you have a young patient with retinoblastoma, then that young patient should have leukocoria. Leukocoria is this presentation over here. Okay, okay. So have you guys heard about leukocoria? Leukocoria at least. Leukocoria. Do we have anyone who have not heard before? Okay. Yes, no. Have you guys heard of leukocoria? Okay, very good. Okay, so nothing new over here for you guys. Okay, you guys have heard leukocoria, and the most important question regarding leukocoria is, what is the indicator of the presence of leukocoria? The indicator of the presence of leukocoria is retinoblastoma. What is the genes associated with retinoblastoma? Can I get some fast answers, please? Feel free to unmute yourself because we're going to draw thing. Okay. So, what is the most gene associated with retinoblastoma?
retinoblastoma gene.
What is the gene?
Retinoblastoma, same.
RB, right?
One.
RB is the name of the gene RB, or yes or no?
Yes.
Yes,
Yes.
yeah.
Okay. What other cancer is associated with RB?
Osteosarcoma.
Very good. Osteosarcoma. Okay. Okay. The next thing which I'm going to draw over here is okay. Okay. So what we are going to draw over here are the visual pathway. Okay. The visual pathway is extremely important for us to understand, and we have a lot of things in between our informations about the visual pathway. But we today in ophthalmology, what we are doing is we are focusing on the high yields first, and then we will go on the lesser yields one. So visual pathway is extremely high yield. Okay. Visual pathway is extremely high yield. And okay, 1 second. Sorry. Just give me 1 second. It won't take me that long to make the visual pathway. Okay. Okay. So since you guys are replying via okay voice, okay, so if I ask you something, please tell me the answer right away. Okay, so first of all, okay, okay. So this is the left, this is the right. Now I will need my I will need our students to help me complete the pathway. Okay, first of all, okay, first of all, if I draw this structure over here, what is the name of this structure?
Optic chiasm. Oh,
Optic nerve.
nerves.
optic nerve.
Optic nerve. Very good. Optic chiasm is coming. Okay, then what is, if I draw something like this?
Optic tract.
Optic chiasm.
This is optic chiasm. This is optic nerve, right?
Yes.
And what is this one?
Optic
Tract.
tract.
Optic tract.
Very good. Okay, so we have the optic tract. It is coming over here. Okay, and then from over here, what happens is the optic tract. Okay, 1 second. From over here, the optic tract, one track goes like this. Okay, and one tract goes like this. Okay, also the same things are happening over here. Okay, this, and then this comes, one track goes like this, one track goes like this. Okay, okay, if this is the optic nerve, if this is the optic chiasm, this is the optic tract. Okay, now my question is, okay, now my question is, where is, in which part of the brain is this track going to? Do you guys have any idea?
Temporal.
Temporal lobe.
Temporal lobe.
Of this, what is the name of this structure?
Radiation.
Meyer's loop.
Ear lobe.
Very good, very good. This is known as Meyer's loop. For anyone, for the students who could not answer, who are not familiar with this tract, okay, we will talk about them. Do not worry. So information comes, okay, information comes, let's say from, okay, let's say that from over here, okay, you have the right and then you have the left. Okay, so that's what's happening. Okay, okay. So if I have to talk about the information, now let's talk about my temporal vision, my nasal vision, and temporal vision. Okay, okay. So which one of these pathways will cross? The nasal one or the temporal?
Nasal. Nasal.
Okay, so if the nasal one has to go, will the nasal one go like this? Yes or no?
No,
Cross.
يديك الصيت.
No,
Yes or no?
Cassettes.
Yes or no?
no. Opposite. To the temporal.
Very good. Okay. The nasal will go like this. Very good, guys. The same way over here, nasal would go like this. Okay. If the nasal is going like this, okay. So if I draw a line over here, if I draw a line over here, A, B, then once again, C and D. Okay. Now, which one of these two letters, which one of these letters will the nasal pathway see?
A and D.
Very good. So the nasal will see this side and this nasal will see this side. Is everyone clear about this? Do we have any confusion? Let's see. Do we have any confusion? Now's the time to tell me. Is anyone confused about what just one? I will take repeat. Okay, perfect. First of all, what's going on over here? You have your left eye, your right eye, optic nerve, optic chiasm, optic tract, Mears loop. Okay, so in your eyes, you have two parts of the eyes which are responsible for two visions. One is the nasal and temporal. The nasal part sees the temporal vision, right? Because the nasal part will see like this, and the temporal part will see the nasal vision. Okay, so let's say if this is the eye, okay, if this is the eye, okay, if this is the nasal, this is the temporal part, okay, then the vision will be like this. So information from this part of your image will go like this, and information from this part will go like this. Are we clear about this? Yes or no?
Yes.
Okay, did you understand, Dr. Nadine? Did you understand? Can we move forward? Okay, perfect. Thank you. And now we're talking about the temporal one. Now, which of the letters will the temporal see? It's easy.
B and C.
B and C, correct. Okay, so these are the only ones that are left. So that's what it is. So the temporal will go like this. Okay, temporal will go like this. Okay. Okay, good. Now my question is, okay, now my question is, okay, one second, let me just clear everything away because it's getting too confusing. Okay, so now you guys understand the visual pathway. Okay, that's what it is. Okay, right now, if I draw two eyes over here, okay, if I draw two eyes, okay, one second, thank God for the shapes. Okay, okay, so right now, okay, and right now, if I have a lesion, okay, right now, if I have a lesion over here, if I have a lesion over here, okay, my first lesion is over here. Okay, what will I see? Will I see anything with my right eye? Yes or no?
Yes.
No, no.
No.
It's at
Any
the
vision.
level of the nerve.
Okay, so if this is my left, if this is my right, so vision for the right eye is gone. Okay, so my vision for the right eye is gone. What is the name of this condition?
Right, anopia.
The name of this condition is anopia. Anopia. If this is on the right side, it's called right anopia. If it's on the left side, it's called left anopia. Okay, this is the first number one visual field defect. Are we clear about this? Yes or no?
Yes.
Yes.
Okay, perfect. Okay, next one. If I have a lesion over here, okay, okay,
By temporal.
which vision can I not see? Which part of the visions can I not see?
Temporal fields.
Anopia.
So okay, we know that the nasal over here and the nasal over here, they're collecting information from this side. They're collecting information from this side. Okay, so as a result, this thing. Right now, if we have a lesion over here, then we cannot see this one. We cannot see this one. Okay, so our vision would look something like this. Okay. Okay. Now, what is this lesion called?
Bitemporal.
Anopia.
Bitemporal.
Bitemporal.
What is the most common cause of bitemporal hemianopia? We talked about this yesterday.
prolactinoma.
adenoma.
Pituitary adenoma.
Retinoma.
Noma. Okay. Very good. Okay. So far it's easy. And okay. Okay. Next one. Next one is if I have, okay, now things can get a little bit complicated, okay, but just be patient, okay, and have your trust. Okay, right now, if I have a damage of the optic tract, right now, if I have a damage of the optic tract, okay, and okay, what would happen is we know that the what are the pathways that are going through here? The pathways that are going through here is the nasal one
Yeah, the temporal of right.
and
The
this one.
temporal.
Mm.
Okay, so we cannot see this side and which one? And we cannot see
Medial.
see this
The
side.
medial.
Nasal.
Medial, yeah.
Right. So
Nasal.
as a result, can we say that our vision would look something like this? So if this is the left side and this is the right side. Okay. So can we say that our vision looks something like this? Yes or no?
Yeah.
Yes.
Okay. So it's a left-sided temporal gone and right-sided nasal gone. Okay. What is the name of this condition?
Left
Left
Left.
hemanymus hemanypia.
homonymous. أيوه. Homonymous.
Okay, this is known as homonymous
Hemano-
hemianopia. And if it's on the left-sided tract, then it's left. If it's on the right-sided tract, then it's right. Are we clear?
Yeah.
Do we have any confusion regarding this?
No.
I'm sorry. I'm sorry. If it's on the right-sided tract,
Yeah,
unless- exactly.
Left.
If it's on the right-sided tract, it's
it
called
left.
left hemianopia.
Mm.
If it's on the right-sided tract, if it's on the left-sided tract, it's called right.
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 Okay. Are we clear now?
Yes.
Yes.
Okay. Why is it only called the left-sided hemianopia and why not right? Because you cannot see the left side completely. Do you guys realize that
Yes.
your left-sided temporal and left-sided vision is lost? That's why it's called left-sided hemianopia. And this occurs due to the right optic tract damage. Okay. Okay, perfect. Okay, let's delete everything. Okay, 1 second. Okay, next one. Next one is if we have a patient right now with damage to, okay, before we do that, so this is Mears loop, which goes to the temporal lobe. Okay, this is the Mears loop. Which lobe does this go to? Temporal lobe.
For
This one go to occipital.
This one goes to?
Visual.
Occipit-
Yeah.
Occipital.
Visual cortex.
So we have the dorsal optic radiation, okay, dorsal optic radiation, which goes to the parietal, and then we have another one which goes to the occipital lobe. Okay, so that's
Yes.
it. Okay, so what happens is if we have a lesion of the Mears loop, okay, if we have a lesion of the Mears loop, the most common cause of a Mears loop lesion or a temporal lobe lesion, what is the most common cause of a temporal lobe lesion due to which
Brain tumor.
which arteries ischemia or stroke?
middle
MCA.
cerebral artery.
Middle cerebral artery.
Middle cerebral artery. We know that the cerebral artery is responsible for supplying the blood to the temporal lobe of the brain. Okay, and if we have a stroke or ischemia of the middle cerebral artery, then the Mears loop will get damaged. Okay, and if the Mears loop will get damaged, the Mears loop is responsible for, before you tell me anything, the Mears loop is responsible for seeing this part.
Quadr.
Okay, for seeing this part. Okay, so information, what happens is it gets divided into upper and lower quadrant. And upper quadrant images on the on one side is seen over here, and upper quadrant images on this side is seen over there. So if the lesion is on this side, the patients cannot see this part. Okay, this is known as
Upper
Quadrantanopia.
quadrantanopia.
right. This is known as left upper
Quadrantanopia.
quadrant enopia. Left upper quadrant enopia. Okay, left upper quadrant enopia. Now, if I were to tell you guys that the lesion is like this, What is your answer?
Right.
Right
Right
upper
upper
quadrant.
quadrant.
Yeah.
And the damage is on this side, right?
Yeah.
Okay, the damage is on this side. So this is known as, this was known as upper quadrantopia, and this is the left-sided one, since this is the left side which is gone. Okay. Okay, next one. Next one is if you have a lesion. Now let's say if you have a lesion of this one. This one is responsible for the lower one. If you have a lesion of this one, okay, what will happen is you cannot see this part of the image.
Excuse me, doctor.
Yes.
Someone waiting.
Okay.
Okay, thank you.
You are welcome. Okay. Okay, Dr. Zahar Yusuf. Okay, how many things did you miss? Did you miss a lot of things? This was really important. Okay, I need you guys to understand. Everyone should understand this. So if you missed out on something, please let me know. I will repeat it for you. It was my mistake. Okay, that was my mistake. I did not see who was waiting or who was not waiting. Okay. Okay, so right now we were talking about this lesion over here. Okay, and if this is the lesion and we cannot see this part, what do you think is this lesion is called?
What lesion? Sorry.
Left
What?
quadrant.
Lower.
Left
Left
lower.
lower.
Lower quadrant.
Lower quadrant anopia.
Anopia.
Lower quadrant anopia. And since once again, this is the left side and this is the right side. So this is known as left lower quadrant anopia. Left lower quadrant anopia. Okay. And this is because of your damage to the dorsal optic radiation, which goes to the parietal lobe, And what is the artery that is responsible for supplying the blood to the parietal lobe?
Middle cerebral artery.
Very good. So a middle cerebral artery stroke can either damage the parietal lobe
Or temporal.
or I mean that temporal lobe or parietal lobe. Okay, so if it damages the temporal lobe, then it's a upper quadrant anopia. If it damages the parietal lobe, it's a lower quadrant anopia. Are we clear?
Yes.
Yes.
Okay, next one. Next one is very easy to understand. Okay, next one is very easy to understand. Next one is right now you have this image. Okay. Next one is you have this image over here. Okay. Okay. What do you think is the problem with this vision?
Left.
Posterior cerebral artery.
Posterior cerebral artery. But why is there?
MCA.
Macula sparing because
Very.
it's supplied by mid cerebral artery.
Why is the
Macula.
Have two blood
Middle
supply.
cerebral artery.
Blood supply.
Macula spares because of MCA supply.
Okay. Perfect. Everyone is correct. The damage is due to posterior cerebral artery. As a result, the patient has, what is the name? Left hemianopia. Along with that, there is macular sparing. Why is the macula spared? Because the macula is supplied by middle cerebral artery. Okay. So this is the PCA stroke. PCA stroke will look something like this. And do you guys remember we talked about this in the stroke topic?
Yeah. Yes.
Okay, so we talked about this in the stroke topic. Okay. Now is the very easy one. Okay. And I know every one of you guys will start shouting MC. Okay. So this is what will happen. Okay. What is the diagnosis of this patient?
Scotoma.
Okay, so none of you guys shouted. Okay, so only one of you guys said this is
Scotoma.
scotoma. Okay, what is the artery that is responsible?
Middle cerebral artery.
Middle cerebral artery or macular degeneration. Macular degeneration. Okay. Okay, so having said that, we are done with all the visual field pathways. Now I will need, okay, now everything will go. Okay, now, okay, so could you guys please go to page number, what was the page number? Let's see. Okay, what was the page number? Page number 540, 542. Was it 542? 542, right? Was it page number 542? Yes, page 542. Okay, so I need you guys to read this once, one time. I will need you guys to read this whole thing one time. Okay, and after that, I will need the help of one physician who will help me complete the visual field defects. Okay, so you guys get exactly how many minutes? You guys get 1 minute. Okay, you guys get absolutely 1 minute. In that 1 minute, you guys will help me complete the visual field defects. Okay, please let me know after you guys are done. Okay. Is anyone?
Yes.
Why do I need you guys to read this right now? I would need you guys to read this because there's no time for you guys to read this at home because you guys need to focus that time in doing first aid. I mean, in doing you all. Okay. Okay. Roughly. Okay. So is anyone ready?
Yes.
Okay. Okay. 1 second. I'm just playing around with the circles. 1 second. Just find the perfect circle. Okay. That's what it is. Okay. Let's see how many physicians we have. Done. Okay. So how many physicians? Okay. Do we have? I would need the help of at least 2 physicians. Okay, if you guys want to perform, just say yes or no or done. Okay, so done. So one doctor said done, so that's Dr. Lala. Is there anyone else who is confident to help me out? Okay, Dr.
Yeah.
Imran. Okay, good. Dr. Adam is also done. Okay. Anyone else? Dr. Hussein, Dr. Hussan. Okay, so we have a lot of students. So all I need is 2 students for now, and I will ask you guys to help me out later. So first of all, let me ask Dr. Lala. Okay. Um, so this is the left eye, this is the right eye. Okay. Now, so would you be kind enough, Dr. Lala? The first question for you is if you have a right-sided optic nerve lesion, okay? Okay, that was not my question. I gave away the answer. Okay. 1 second, I'm sorry. Okay. What is this diagnosis? What is this diagnosis? Dr. Lala. What is this diagnosis? Over here? Can I get some answers? Can you guys hear my voice?
Yeah.
Yes.
Yes.
Okay, so
Yeah.
Dr. Lala, you said you wanted to perform. So, okay, so can we get the next physician, Dr. Iman? Okay, let's ask Dr. Iman. Dr. Iman, what is this?
Right
What,
anobia.
perfect, thank you. We don't have a lot of time, okay? So we will move on. The next one is, what is the name of this lesion?
Bitemporal hemanobia.
Okay, can we ask the next question to Dr. Adhanom, Dr. Adhanom, who also wanted to perform? Okay, if you have if you have a lesion like this, where is the damage? Where
Optic
is
chiasm.
optic
Optic
chiasm?
chiasm.
Optic chiasm. Okay, very good. Next one is what is the name of this lesion?
Left homonymous hemanopia.
Okay, where is the problem?
In the right optic tract.
Very good, right optic tract. Okay, the next physician I believe was Dr. Samra Hussain.
Yeah.
Dr. Hussain, would you be kind enough to tell us what is the problem with this patient who cannot see this thing?
right upper, left, sorry,
Okay, this is the
right
left.
upper quadrant anopia.
Shouldn't this be the left upper quadrant anopia?
Yeah,
Because-
left upper quadrant anopia, lesion in right side, sorry.
Okay, perfect. Where is the lesion? Where is
My ear, in my ear, temporal part,
Mears loop? Okay, very good. Mears loop. And what artery is damaged?
middle cerebral artery.
Okay, thank you so much, Dr. Hussein. Can we ask the next question to Dr. Hossam? Okay, Dr. Hossam. Okay, what is the damage over here, Dr. Hossam?
Yeah, dear. The damage here is lower lower right, lower quadrant, right hemanopia, right homonymous hemanopia.
Is it the left side or the right side?
Right side, yes.
How is this the right
Yes.
side, Dr. Hossam?
Left.
This is the left side. Okay, the patient.
Doctor, I'm actually confused in this, like
Okay,
right hand. You can see the chat. I asked you before.
no problem, no problem. Okay, so this is the right, this is the left, and if the lesion is okay, now is it clear? Which side is the lesion? Left side or the right side?
Left,
Left. That is your answer. Is it upper quadrant anopia or a lower quadrant anopia?
lower.
Lower. And where is the problem? Which
In the,
structure is the issue?
in the Myers loop.
Nope. The Mears loop is
No.
responsible for
Yeah,
this
yeah.
one. This
In
is for,
the radiation. So yeah.
okay. So this is for the dorsal optic radiation. Which lobe is this going to? Temporal or parietal?
Parietal.
Parietal lobe. Which artery is damaged?
MCA.
Very good. Okay. I heard someone say MCA, MCA. Okay. So MCA. Okay. So that is okay. So that's what it is. Okay. So that's that. Okay. Okay. Very good, guys. Okay. Next one is if you have this one over here. If you have this one over here. Okay. Who should I ask the next question to? Let's see who else is here. Okay, no problem. So can we ask the question again to Dr. Adhanom? Okay, Dr. Adhanom. What is
Yeah.
the name of this problem? Very fast. We don't have a lot of time.
This is by tempo, both of them.
Yes. What is the name of this problem?
This left-sided hemanopia with macular sparing.
Perfect. Left hemianopia with macular sparing. Left hemianopia with macular sparing. And now, what is the name of this issue over here?
This is the cherry spot.
Nope. This is central scotoma.
Central
This is
scotoma, yeah.
central scotoma. Okay. Are we clear? Do we have any issues? Do we have any confusion regarding this?
Yeah, I have question.
Okay, well, let's see
Uh,
what's the question. What is
Is
your
is macula supplied by posterior cerebral artery and middle, or only middle cerebral artery?
which one?
Macula.
Macula. Macula is mostly supplied by middle cerebral artery.
Okay.
Okay,
Thank you.
any more question?
No, thank you.
Okay, does anyone have any more question? No, okay. Did you guys understand the visual field defects? Because it's extremely important. If you guys don't understand this, then there is no point of reading ophthalmology today at all. Because the only questions you will get from USMLE step 1 is about the visual defects. Are we clear about the visual field defects?
Yes.
Oh, can you please repeat the left hemianopia with macular sparing? Of course, I will repeat the left hemianopia with macular sparing. Okay, so once again, what's going on with the left hemianopia with macular sparing is if you have the eyes over here, okay, and this thing is going all the way where? Then you have Mears, temporal, and then eventually what happens is these things, they go to they go to the occipital cortex. Okay, they go to the occipital cortex. Now, if you have a PCA stroke, this part, so everything from this side they will not see. So everything will be gone from this side. If it's the right side one, everything will be gone from that side, except that the macula will be spared. Excuse me. Except the macula will be spared. Why will the macula be spared? The macula will be spared because the macula is supplied by middle cerebral artery. Okay, and at the same time, if you have only damage of the optic tract, okay, then the patients will have complete left hemianopia, including the macula, okay, because the damage is not with the artery, the damage is with the nerve. Okay, and now if you have the damage with the artery, then this will be like this. Are we clear now? I just did left homonomous hemianopia. The lesion is in the optic tract. Okay, the lesion is in the optic tract. Okay, are we clear now? Yes, you can say it right or left depending on which part, depending on which scotoma it is. If it's on the right side, it's called a right central scotoma. If it's on the left side, it's called a left central scotoma. Okay. Yes, you had so many questions about this in UWorld, but if you get questions about this in UWorld, will you be confident to answer this right now? Is this so? Because we're really taking our time to break everything down. Okay. Okay, thank you so much. This makes us very happy that you are confident to answer questions about this in UWorld. Okay, and we wish you all the very best so that you guys can do well in your UWorld questions regarding the visual field defects. Okay, so if we are done with the visual field defects, now let's move on to other topics. Okay, 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 good. Okay, let's start with the pupillary control or the pupillary reflex. Okay, is everyone clear? Can we move on to the next defects, next group of defects? Okay, good. So the next thing is we would be talking about the pupillary control. The pupillary control. What is the pupillary? What does the pupil do? The pupil constricts. This is known as meiosis. Constriction is done through parasympathetic. Okay, constriction is a parasympathetic activity. Okay, so what's happening here is, if you can see my image, you can see the pathway which we just discussed. But what happens is the pathway. What this does is let's track the pathway. So we have the optic nerve, optic chiasm, optic tract, and this goes all the way back to this nucleus. This is known as pretectal nucleus. Okay, this is known as pretectal nucleus. So the pretectal nucleus, what this does is, if you have information from the right side, okay, this information will go to the right pretectal nucleus. Okay, this information will go to the right pretectal nucleus, and from the right pretectal nucleus, this information will go to both left and right Edinger Westphal nucleus. Okay, this information will go all the way to left and right Edinger Westphal nucleus. Okay, and what would happen is, so you have one information coming from the right side. This one information goes all the way back to this one nucleus called pretectal nucleus on the right side. The right-sided pretectal nucleus sends information to both left-sided Edinger Westphal nucleus and right-sided Edinger Westphal nucleus. And what happens is, when they send this information, what they do is they transport or transmit this impulse all the way back by the help of oculomotor nerve or third cranial nerve. And that's why you get, when you close this eye, I mean, when you, let's say you put light, okay, this is a torch, let's say you put light into this eye, and this eye has no light coming through it, but the pupils of both eyes will constrict. This is known as pupillary light reflex. This occurs because the pretectal nucleus receives the information and it sends the information to the Edinger-Westphal nucleus. And from the Edinger-Westphal nucleus, this goes all the way to the to this one, to the um, left-sided eye. As a result, you get both right-sided pupillary constriction and left-sided pupillary constriction. That's exactly what happens. Have you guys understood pupillary light reflex? Okay. Okay, once again. Okay. Okay, so what's happening over here? Okay. So what's happening over here is you have this eye, then you have this eye. Okay. Okay. What's going on is you have information that is coming from this side. Okay, and this is the nasal information. This is the nasal vision. Okay. This comes all the way. This comes all the way over here. Okay, and what happens is, this comes and this comes to this nucleus called pretectal nucleus. Okay, this comes to the pretectal nucleus, and when you have pretectal nucleus, the pretectal nucleus sends information to another nucleus, another both nucleus. So it sends one information to this Edinger-Westphal nucleus, and it sends another information to this Edinger-Westphal nucleus. As a result, the Edinger-Westphal nucleus of this side, the Edinger-Westphal nucleus is the nucleus of oculomotor nerve, and the Edinger-Westphal nucleus of this side is the nucleus of oculomotor nerve. As a result, one impulse was enough to stimulate two oculomotor nerves. One impulse was enough to stimulate two oculomotor nerve. As a result, what happens is one light was enough to cause pupillary constriction of both sides. Although keep in mind that the light was not focused on this eye. So as a result, this is known as pupillary light reflex. Okay, so what happens in pupillary light reflex? You ask the patient you put your hands in the middle so that this eye cannot see the light, and you put light onto this eye. And when you put light onto this eye and you see that and you ask the patient that, okay, can you see the light in your right eye? And the patient will say no. So then you shine the light in this eye, and you see that the pupils in this eye will constrict, and even though the light is not there in this eye, the pupils on this eye will also constrict due to the fact that the pretectal nucleus is sending information to these two Edinger-Westphal nucleus, and at the same time there is bilateral pupillary constriction. This is known as pupillary light reflex, and I'm pretty sure I should not be the first one to teach you guys about pupillary light reflex, because pupillary light reflex is a very basic it's a very basic knowledge. Okay, so but still, since a lot of us are all graduates, and we have a lot of issues, we forget our basic sciences, and that's completely normal. That is very normal. If you guys need me to teach you this again, I have absolutely no problem. But have you guys understood about the pupillary light reflex?
Yes.
Okay. If you're still confused, the time to let me know, because if I move forward, then it will be difficult for me to come back over here. Questions? Couldn't understand it, but very clear now. Okay, great. Okay, great. Thank you so much for putting your attention and understanding the pupillary light reflex. Okay, next one. So what's going on is, so you have the first neuron, which is the Edinger-Westphal nucleus. So they're talking about constriction. Okay, the first neuron is Edinger-Westphal nucleus. And then the second one is short ciliary nerve, which goes to the sphincter pupillae. Okay, short ciliary nerve. Okay, so that's that. Okay, okay, so that's what it is. Okay, next one is, so we just talked about the pupillary light reflex. Okay, so what's happening once again? Light coming from over here goes to the pretectal nucleus, goes to bilateral Edinger-Westphal nucleus, via the oculomotor nerve. This goes all the way to the ciliary ganglion. Okay, so the ciliary ganglion, you have the short ciliary nerve, which goes to the sphincter pupillae and causes constriction of the sphincter pupillae, and then you have pupillary constriction. This is your pupillary constriction. Okay, now if I tell you that, you shine the light in one eye, let's say in the right eye, and the left eye does not constrict, but the right eye constrict. Do we have a problem with the optic nerve or with the oculomotor nerve? Which sided oculomotor nerve? Which sided? The side which did not constrict? That's the problem. Okay, my next question is, if you shine the light in one eye and none of the eyes constrict, okay, where is the problem? Very good. Okay. Next one is next one is if you shine the light in the right eye and the left pupil constrict, but the right pupil in which the light is being shown, it does not constrict. Where is the problem? Very good. Oculomotor nerve. Okay. Okay. Now, if I tell you that the patient's optic nerve and oculomotor nerve both are intact, but the right eye has pupillary constriction, but the left eye has no pupillary constriction, although both oculomotor and optic nerve is intact. Which nerve do you think has the problem? Ciliary nerve, very good. Short ciliary nerve. It's not Edinger Westphal nucleus, it's short ciliary nerve. Okay, short ciliary nerve. Repeatedly, yes, very tricky here because we have to understand the basic part. Oculomotor nerve from the ciliary ganglion. From ciliary ganglion, it goes to the sphincter pupillae by the short ciliary nerve. Now, optic nerve and oculomotor nerve are working just fine, but pupillary constriction is not happening. Why? Because of short ciliary nerve damage. Okay, short ciliary nerve. Okay, okay. Okay, so let's read the pupillary light reflex. What is this? This is basically light in either retina will send signal via the second optic nerve to pretectal nucleus in the midbrain. Okay, this is important. Where is the pretectal nucleus? The pretectal nucleus is in the midbrain that activates the bilateral Edinger-Westphal nucleus, and this results in pupillary constriction. Okay, so that's it. So this results in pupillary constriction. So that's it. And from the and it's in the whole mechanism is important, but don't forget the pretectal nucleus is in the midbrain. Okay. Next one. Next one is mydriasis. Mydriasis is basically dilatation. Okay. Okay. Dilatation. Mydriasis is not that common, so like meiosis is. So mydriasis. What's basically mydriasis is basically dilatation. So sympathetic. Okay. So we know that our eyes get dilated when we want to fight or flight, right? During adrenaline or those kind of things because they help us see better. That's right. So the first neuron is from the hypothalamus. Okay, from the hypothalamus to the ciliospinal center of Budge. That's at the level of C8 to T2. Okay, so ciliospinal center of Budge. That's at the okay. So let me show you what the ciliospinal center of Budge is. Okay. 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 So what's happening is okay. So C8 to T2 is so this region is basically the ciliospinal center of bulge. Okay, so basically what's happening here is you have the first order neuron that is from the hypothalamus, and which area of the hypothalamus is responsible for sympathetic? Which nucleus? Anterior nucleus or posterior nucleus? Posterior nucleus. Okay, for anterior cooling sympathetic, heating. No, sorry, anterior cooling is parasympathetic, and posterior heating sympathetic. Okay, posterior nucleus of the hypothalamus, then it goes to the ciliospinal center of Budge. From there, what happens is they exit the T2 via the superior cervical ganglion. Okay, they exit the T2 via the superior cervical ganglion. This is the superior cervical ganglion. That's where they go to, and that's coming from the hypothalamus. Okay, so from the hypothalamus, they go to the ciliospinal center of Budge. From the ciliospinal center of Budge, they go to the superior cervical ganglion. From the superior cervical ganglion, what they do is they go, this is the second order neuron, and they pass through the lung apex. Okay, so this is, so if this is the lung, okay, they pass, okay, the nerve, what this does is this nerve, 1 second, okay, pass through this, they pass through the lung apex like this, they pass through the apex of the lung, and what happens is they plug along the internal carotid artery, and they enter the orbit as long ciliary nerve. Okay, so they go through the lungs, and then they enter as long ciliary nerve. So first of all, hypothalamus, posterior nucleus, from there ciliospinal center of Budge, ciliospinal center of Budge, then we have the second order neuron, which goes to the superior cervical ganglion. From there they go through the lungs to the apex. From the apex, they go to the internal carotid artery. From the internal carotid artery, they go all the way as a long ciliary nerve to the dilator pupillae, Okay. And as a result, what happens is the long ciliary, they reach the dilator pupillae. If they activate the dilator pupillae, then you have pupillary dilatation. Okay, pupillary dilatation. So now the most important question is, if you have a lung tumor at the apex, okay, will this cause pupillary dilatation or pupillary? Okay, so can you guys hear my voice? Yes, no. Can you guys hear my voice now? Is the voice better? Is the voice breaking now? Okay, good. So, okay, once again, let me show you the pupillary dilatation pathway. So, from the hypothalamus, the posterior nucleus goes to the ciliospinal center of Budge. From there, they have the first order neuron, the second order neuron starts. From there, they go to the superior cervical ganglion. Okay, from the superior cervical ganglion, they pass to the lung apex, then internal carotid artery, then long ciliary nerve to dilator pupillae, and pupillary dilatation occurs. Okay, now my question is, if you have damage or a tumor at the apex of the lung, will there be pupillary dilatation or pupillary constriction? Pupillary constriction, meiosis. What is the name of this? What is the name of this condition? What is Horner syndrome? Very good. And what is the name of the tumor of the lung at the apex of the lung? Pancoast tumor. Very good. Pancoast tumor. If we have a Pancoast tumor, and this causes a brachial nerve palsy, which nerve is the most common to get innervated or paralyzed from the brachial plexus? Lower trunk. Which nerve? Axillary nerve is not the right answer. Not the right answer. Axillary nerve is not the right answer. Another nerve, please. Another nerve. Radial nerve is not the right answer. Okay. Which nerve of the brachial plexus? It's ulnar nerve. Nope. It's ulnar nerve. Ulnar nerve. The ulnar nerve, the medianmost branch, the median cord will get the median cord will get pushed or denervated. As a result, patients will complain of back pain and tingling sensations in the last 1.5 digits. Okay, this is a UWorld question. This is a question from UWorld regarding Pancoast tumor. Please write it down in your book. Write it down in your book. Okay, did you guys write it down? If you have a Pancoast tumor, which nerve of the brachial plexus is the most common to get affected? And the answer is ulnar nerve. Write it down in your book. After writing it down, please let me know. Okay. Okay, good. Next one. Next one is Marcus gun pupil. And what is the disorder associated with Marcus gun pupil? Where did we talk about Marcus gun pupil last time? MS. Or anything else? Anything else? Where did we talk about Marcus gun pupil? Syphilis. There we go. Charcot joints, right? Do you guys remember Charcot joints and then Marcus gun pupil? Do you remember? Yes or no? Oh, sorry. Yes, that was Argyll Robertson pupil. Right, that's correct. Argyll Robertson pupil and Marcus gun pupil was for MS. You guys are correct. Okay, I got confused. Okay, Argyll Robertson pupil. Okay. So when we discussed Marcus gun pupil, do you guys remember Marcus gun pupil? What did we discuss about? Okay, what is Marcus gun pupil? What is Marcus gun pupil? Okay, so basically, what is Marcus gun pupil? This is also called a relative afferent pupillary defect. Okay, when the light is shown into normal eye, there's constriction of the ipsilateral. So ipsilateral constriction and contralateral eye is observed. Okay, but when the light is shown into the affected eye, meaning the eye that is affected, okay, both the pupils will dilate instead of constrict. Why? Due to impaired conduction along the optic nerve. So this is exactly what I just talked about, that let's say you have an optic nerve damage over here. Okay, you have an optic nerve damage over here. If you shine the light in the left eye, both left eye will constrict and right eye will constrict because the oculomotor nerve on left and right is working just fine. But if you shine the light into the right eye, then the right eye will not constrict and the left eye will not constrict. Why? Because the both left and right eye is damaged, because the optic nerve in the right eye is damaged. Okay, So have you understood Marcus gun pupil? Yes, this is a UL question. This is a very important UL question. Okay. Okay. So once again, Marcus gun pupil, which condition is it associated with? Marcus gun pupil, MS. Argyll Robertson pupil, which condition is it associated with? Syphilis. Okay, syphilis. Okay, don't get confused like how I got confused. Okay, so syphilis and okay, what is Argyll Robertson pupil? Argyll Robertson pupil is basically accommodation is okay, but the pupils will not react to light. So good accommodation, but no reaction. That is Argyll Robertson pupil. Okay, are we clear? Okay, do we have any more questions? You are absolutely welcome, no problem. Okay. Next one. Next one is how many things do we have? Let's see. Okay, we are very close to finishing these things. Okay. So before we move on to the next topics, do you guys want to take a 5-minute break? Yes or no? Okay, because it's getting a bit too much. Even I'm getting confused. Okay, because too much for us to handle because ophthalmology is very big, but we are willing to finish it by today by hook or crook. Okay, no matter what. Okay, so 5-minute break. Okay, we'll come back at 12:45. Okay, is everyone back from their break? Is everyone back from the break? Okay. Okay, we were supposed to take a 5-minute break. It became a 10-minute break. Okay, so is everyone refreshed? Okay. Okay. So what we are going to discuss now is we are going to discuss about, okay, 1 second. Okay. Okay. So we are going to discuss a very important topic right now. And the topic that we are going to discuss right now is internuclear ophthalmoplegia. Okay, the topic that we are going to discuss about is internuclear ophthalmoplegia. Can you guys hear my voice? Is also can you guys hear my voice? Okay, good. Okay, good. So the next high yield topic that we will discuss right now is internuclear ophthalmoplegia. So what we will do is I would go back to my drawing pad, and if anyone has a question, please unmute yourself and ask me. And if I ask you a question, please feel free to answer because we need to save time. I cannot come back to the chat box and see who's writing what. And at the same time, if you notice anyone who's waiting to join, please let me know. Okay. Okay, good. So with that being said, first of all, what is internuclear ophthalmoplegia? Internuclear ophthalmoplegia, very simply put, is the condition in which, that, let's say that this is your eye. Okay. Okay. Let's say that this is your eye. Okay. And this is you. Okay. And right now, if you want to look to the left side, okay, if you want to look to the left side, then how should your eyes look? Okay, if you want to look to the left side, how should your eyes look? Your eyes should look something like this. Okay, right? You should look, both of your lenses should move in this side, and your eye should look something like this. Your eye should deviate all the ways like this. So what happens is, what is internuclear ophthalmoplegia? Internuclear ophthalmoplegia is basically that condition in which you want to look left, but okay, so this eye looks forward, and this is the only eye that looks to the left side. This is known as internuclear ophthalmoplegia. Okay, and what is the most common disease in which where we see internuclear ophthalmoplegia? Can I get some fast answers, please? Can I get some fast answers?
Multiple sclerosis.
Multiple sclerosis. That is correct. That is correct. Now let's see how is what's the mechanism behind internuclear ophthalmoplegia. Okay, what's going on with internuclear ophthalmoplegia? Okay, okay. So you have two eyes over here. Okay, so you have two eyes over here. First of all, the thing that I want to draw is, first of all, the thing that I want to draw is, I want to draw the medial rectus, and I want to draw the lateral rectus. Okay, so this is the medial rectus, this is the lateral rectus, and once again, this for this eye, this is the medial rectus, and for this eye, this is the lateral rectus. This is all we drew. This is all we drew right now. Now what happens is, okay, now what happens is, you have now what happens is, okay, so you have, if you want to look to the if you want to look to the left side, which part of your brain should get activated, right side or left? If you want to look to this side, if you want to look to this side, which part of your brain should get activated, this side or this side?
Right.
Very good. Okay, we know that the right side controls the left side controls the right. Okay, so this is your right side. Okay, so now we're trying to look this way. Okay, so this is your right-sided brain. This is your left-sided brain. If you want to look this side, then this brain should get activated. Okay, so your right side has a region. The brain has a region. This region is known as the frontal eye field. Do you guys remember the frontal eye field? We talked about this. Yes or
Yes.
no?
Yes.
Yes.
Yes. Yes, you guys remember the
Yes.
frontal eye. So first of all, let's say you in your brain, in your prefrontal cortex, you make a decision that you want to look to the left. It's a very simple decision. So you make a decision that you want to look to the left, and that decision, okay, that thought becomes an, what does the thought become? I talked about this. Thought becomes what? Thought becomes an idea becomes an action. Do you guys remember that?
Yes.
You remember I talked about that in the prefrontal cortex. Okay, if you think about doing something, that first is the thought that you think you will look left, and then that thought becomes an idea about how you will do it, and that idea becomes an action. What is the action? The action is the prefrontal cortex. It travels all the way to the frontal eye field over here by the white matter, that is corona radiata. From there it goes, that is from the right frontal eye field. Okay, this decision, where does it go? Okay, this decision goes all the way to where? To this nucleus over here. I said I will talk about this nucleus, and this is the perfect time. This nucleus. Okay, this box-like nucleus on these two sides. Okay. This is known as
Charge.
PRF. What is the full form of PPRF? Fast answers, please.
Parapontine.
Parapontine reticular, paramedian pontine reticular formation. Paramedian pontine reticular formation. And where is this located? Midbrain pons or
In
medulla?
pons.
Pons, because the name says so. PPR.
Pontine.
Paramedian pontine reticular formation. There's another nucleus which is just below the pontine nucleus. Okay, this nucleus over here. Okay. And do you guys remember we talked about the fact that, do you remember we drew the structure of pons and we had things coming off like this? Do you guys remember this? The cranial nerves?
Yeah.
Yes or no?
Yes.
Okay. What is the name of this cranial nerve?
6.
6.
Very good. Okay. So what is the nucleus right beneath paramedian pontine? What is this nucleus?
Abducens nerve nucleus.
Right. So abducent nerve nucleus. Okay. Okay. Now we will draw another nucleus. This nucleus is, okay. Do you also remember that when we drew the pons, okay, we mentioned these two nucleuses, these two nerves, which were coming, but it was going above the pons. What was the name of these two nerves?
4.
Above the
6, 7.
Curricular.
very
Seven.
good. Very good. 3 and 4. Okay. So if there has to be a nucleus above the pons, that nucleus is the third cranial nerve nucleus. Okay. That nucleus is the third cranial nerve nucleus. Okay. So far, what did we draw? We drew two eyes. We drew two muscles, medial rectus, lateral rectus. We drew the right frontal eye field. Then we drew paramedian pontine reticular formation. Then we drew abducens nucleus. Then we drew oculomotor nucleus. Okay. Okay. Before I move forward, let me just remove the labeling so that it's easy for me to draw the nerves. Okay. Okay. Have you guys understood all the structures till now? Yes or no?
Yes.
Okay. Do we have any confusion from any doctor? If you have confusion, please let me know. If we move forward, it will get difficult for me to understand. Okay. Do we have any confusion? Yes or no? No. Okay. Hopefully no confusion. Okay. Right now. So what's going on? What's going on is, so you want to look to the left. So you make a decision. That decision turns into an action. That action gets transferred from the prefrontal cortex by the white matter, that is corona radiata, all the way to the right frontal eye field. Now the right frontal eye field, okay, now the right frontal eye field will make a decision that you will look to the left. How will that happen? So it will send impulses. Where will it send impulses? The first impulse it will send to is here. That is paramedian pontine reticular formation. Okay, after it sends impulses to the paramedian pontine reticular formation, what this will do is this impulse will go from here to the Fast answers, please. What is
Abducent
the
nucleus.
Abducent nucleus.
Yes.
oh, abducens? From the abducens, okay, from the abducens, another group of impulse will grow to which nucleus? What is the name of
Oculomotor.
Water.
Ocular.
oculomotor nucleus? And abducent nerve will send its own impulse
Lateral
to
rectus. Lateral rectus.
which lateral rectus?
Lateral rectus.
Very good. It will send impulse to the lateral rectus. Okay. 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 So as a result, what happens is, and now the oculomotor nerve over here, which one will it go to?
Medial rectus.
Rectus.
Medial rectus. Okay. Right now, if the lateral rectus constrict, okay, if this pulls because of abducens, and if this pulls because of medial rectus, which way will these two eyes move?
The left.
Go to the left.
Left.
Now this is where your eyes will move left. Okay. Have you understood this mechanism?
Yes.
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 Okay. Once again, you want to look left. Okay. Your prefrontal cortex, your brain. Okay. This is your brain. You decide you want to look left. You send impulses to the right frontal eye field. Here. From here, the nerve travels all the way down to PPRF. That is in the pons. From the PPRF, it goes to
Decent nucleus.
abducens nucleus. Abducens nucleus, from there, it goes all the way to lateral rectus via abducent nerve, and another one goes to oculomotor nucleus. And then from there, the oculomotor nerve goes and innervates the medial rectus. As a result, you have the lateral rectus, which is working, and then you have the medial rectus that is working. This is known as ophthalmoplegia. Okay, this is not, I'm sorry, this is not known as ophthalmoplegia. I mean, the lesion, the if there is a problem with this pathway, this problem in the pathway is known as internuclear ophthalmoplegia.
Mm.
Okay, are we clear with this?
Yes.
Okay.
Yes.
Okay. Which one of this is the median longitudinal fasciculus?
From abducent to oculomotor.
From 6 to 3.
From 6.
Which? Just tell me the
Green.
color. Which
Green.
color?
Green.
Green
Oh,
color.
very
Rock?
good. Okay. This is the MLF. MLF is the median longitudinal fasciculus. Is this highly myelinated or not highly myelinated?
Highly
Highly.
myelinated.
Highly.
Very highly myelinated because the impulses are so strong. Okay. Okay. Do you guys have a mirror in front of you? Does anyone have a mirror?
No.
Okay. 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 The reason why I asked you is if you go in front of a mirror right now and if you try to look left, is there a possibility that you can look left with your left eye without looking left with your right eye?
No.
No.
No, absolutely impossible. You cannot do that. But if you can do that, then you have a problem with the median longitudinal fasciculus.
Ophthalmoplegia.
Because this tract is so myelinated, the myelins are heavily myelinated over here. And one of the most important demyelinating disorder is multiple sclerosis. In multiple sclerosis, you have knockouts of the myelins. These myelins are not working. So as a result, what would happen is the impulses will not go. So your left eye will move left, but the right eye will not move left. Okay. Okay.
Okay.
Okay. There was a meme about an Arabian guy. Let me see. Okay, where was the internuclear ophthalmoplegia? Okay, there was this one Arabian guy who could do it. Okay, there was this one guy who could do it without. Okay, he did not have multiple sclerosis, but he could still move his eyes to the left. For somehow, I don't know how he did it. Okay, I will share that image with you guys if I find it. Okay, but this is basically internuclear ophthalmoplegia. Okay, so this is the problem. Okay, so having said that, let's go back to our text. Okay, let's go back to our test. Okay, now let's see what the problem is. Okay, So what the problem is, the median longitudinal fasciculus, this is the pair of tract that follows between 6th and 3rd cranial nuclei. It coordinates the eyes to move in horizontal direction. It's highly myelinated, and the lesions may be unilateral or bilateral. Okay. Okay. All of this text over here is not as important as the diagram. Okay. So the diagram is important. The diagram is extremely important over here. Okay, so the diagram is extremely important. If you want, please take a picture of the diagram and put it in your phone or put it in your laptop so that the next time you guys come across this picture, you can visualize the internuclear ophthalmoplegia, I mean the lesion in the medial longitudinal fasciculus. Now, if there's a lesion in the in the median longitudinal fasciculus, the ophthalmoplegia that you will see is internuclear ophthalmoplegia. Okay, and what would happen is you would have a conjugate horizontal gaze palsy. So the problem that which we just discussed, this problem, this is known as a conjugate horizontal gaze palsy. Conjugate horizontal gaze palsy. Okay, so that's what it is. And basically they are trying to discuss the pathway, which we just did. So they're saying that there's a lack of communication between the 6th nucleus and ipsilateral lateral rectus and contralateral third cranial nerve that does not stimulate the medial rectus to contract. Okay, so that's exactly what's happening. So that's exactly what's happening over here. And once again, we also discussed this, that the lesion is in the multiple sclerosis, that is a median longitudinal fasciculus. When we look left, the left nucleus fires, okay, but the right nucleus does, but since the median longitudinal fasciculus is not working, the right medial longitudinal fasciculus to contract the light right medial rectus fails. Okay, as simple as that, it fails. Okay, so will these patients have diplopia, yes or no? Will these patients have diplopia? Yes or no?
Yes.
Of course, these patients will have diplopia because vision in this part is okay, vision in this part is not okay. So these patients will get diplopia. Are we clear? Are we clear about internuclear ophthalmoplegia? Okay. Does anyone have any question regarding internuclear ophthalmoplegia? Okay. No more question. Okay, no more questions. So we are done with internuclear ophthalmoplegia. Okay. Okay. Now we wish we could have
I have a
started.
question, doctor.
Yes. What is your question?
For example, if the right MLF is damaged, so how is the clinical? Which eye is? What is the clinical manifestation? I mean,
Okay. So if this is the right one.
visualize.
Okay, if the right one is damaged, then which medial rectus is not working? Right medial rectus or left medial rectus?
Right.
Right medial rectus. If the right medial rectus is not working, then this eye will move to this side and this eye will look like this. Similarly, if the left one was not working, then this eye will move to this side and this one will look right.
Yes.
Okay. Are we clear?
Yeah.
Okay. Okay, perfect. Okay, so the confusion can be the fact that the right median longitudinal fasciculus, it arises from the left side of the PPRF. So remember that. Okay, was that your confusion? Was that the question? Dr.
Yeah.
Adamo?
Yeah. Yes.
Is the confusion clear?
Yeah. Therefore, if the right medial longitudinal fasciculus is damaged, the right eye will be abducted.
If the right one is damaged, then the right eye will look forward. The left eye will move to this side only. Okay?
Okay, yeah.
Okay, perfect. Okay. No adduction will occur. Okay? No adduction will occur. They will only look forward. They will not be stimulated because median longitudinal fasciculus is not working. Okay. Okay, completely clear and confident. Why nystagmus? Nystagmus is basically what happens. Okay, so nystagmus, basically what happens is the patients get nystagmus because the eyes try to fix themselves. Okay, so nystagmus, what happens is when the eyes, when one eye looks this way, another eye looks forward like this. Okay, and the another eye looks forward like this. This sends backward impulses, and the eyes tries to look forward. So the eyes tries to move left, the eyes tries to move right. Okay, and this movement of the eye from left to right, this is known as, this causes nystagmus. This is a protective mechanism of the body to prevent diplopia, but it does not work. So that's that. Yes, the eyes will be labeled in the exam. The eyes will be labeled. Okay. Any more question? Okay. I have a question. I have one question for you guys. If you get a picture in your NBME on your or on your UWorld, and when they ask you to locate the PPRF, in which part of the brainstem are you going to look for?
Midbrain.
PPRF.
Pontine.
Pons.
Pons.
Pontine. So
Pons. Okay, pons.
Bones, yeah.
Okay, so there is a question in NBME where they want you to locate the PPRF. If they want you to locate the PPRF, look for pons. Okay, look for pons. If you find pons, you will find your PPRF. Even the median longitudinal fasciculus, you will also find it in pons. Okay. Okay, next one. Okay. Okay. How many things do we have left? Are we very close? Okay. Okay, we still have Horner syndrome. Okay, so let's start with Horner syndrome. Horner syndrome. What is basically Horner syndrome? How tired are you guys? Are you guys very tired? Tired? Yes or no? Okay. Do we have any student over here who is having at least any amount of fun? Because I'm having a lot of fun today because these things are okay. These things are very okay. So no one is having fun today. Okay. Okay. I find it very, I mean, yeah,
interesting.
these are very amusing. These
The
are very
pathways,
interesting.
yeah.
I mean, you get to learn the pathways, you get to learn the different types of, and the best part is I'm going to tell you when it will be fun for you. When you solve the UWorld questions and you get your answers right, then it will be fun for you. Then you will have excess surge of dopamine in your brain and you will be like, oh yes, okay, good. Okay, next time I'm not going to be tired in the lectures anymore. Okay. Okay, so we have a lot of sarcastic people answering sarcastic things. Okay. Okay. So do we have some energy left to study 2 more pages, please, so that we can finish ophthalmology? Okay. If needed,
Yeah.
what we can do is, if needed, what we can do is, I will not pressurize you to solve UWorld notes today. Nor, yes, exactly, Dr. Nadine. Me and you were on the same page. So we can skip out on the UWorld notes. Okay. We will skip out on the UWorld notes, but we will finish ophthalmology. Okay. And because we have to finish ophthalmology because this week neurology has to be finished by hook or crook. Okay. Neurology has to be finished. Okay. So let's begin. This won't take that long. I told you guys that the less important subjects will be left for the last. Okay, so these are not as important as the visual field defects, as the ophthalmoscopic findings, as the internuclear ophthalmoplegia, and I'm pretty sure you guys already know what these are. Okay, so can I get some help from the students? Okay, please help me so that we can finish this very soon. Okay, I would need the participations of some students. If I ask you questions, just tell me the answers right away. Okay, first of all, what are the first 3 things we see in Horner syndrome? Can I get some fast answers, please? Can I get some
Ptosis,
first?
hydrosis.
Ptosis and hydrosis,
Meiosis and
meiosis.
meiosis.
Very good. So what we see is we see ptosis and hydrosis, and we see
And
meiosis.
meiosis.
Very good. So ptosis. Why do we see ptosis? Due to the paralysis of the superior tarsal muscle. Okay, so which nerve is being damaged over here for ptosis to occur? Fast
oculomotor,
answers, please.
Oculomotor.
Okay. Meiosis. Why is meiosis happening over here?
oculomotor.
Now, do you guys remember I told you that the long ciliary
Sympathetic.
nerve is
Sympathetic.
right? You remember how
Yeah.
the
Yes.
hypothalamus, posterior nucleus of the hypothalamus goes to the ciliospinal center of bulge. From there, superior cervical ganglion. From there, the lungs, internal carotid arteries, long ciliary nerve, and then it goes to the dilator pupillae. Okay. If we have an apex tumor, which is blocking the long ciliary nerve, will there be constriction or dilatation of the pupil? Fast answers, please.
Constriction.
Constriction. So as a
Constriction.
result, you see meiosis. So unopposed action of, as a result, that's why we see meiosis. So Horner syndrome is ptosis, anhidrosis, and meiosis. Okay. You first aid has a mnemonic over here, which I personally am not a very big fan of. Okay, so you don't have to remember this mnemonic. You can just remember ptosis, anhidrosis, and meiosis. That's more or less good. Okay, next one. Next one is associated with lesions along sympathetic chain. Okay, the first one, first neuron is okay. The first neuron is okay. The first neuron can get damaged. So basically these are the causes of Horner syndrome. Okay, so what are the different types of Horner syndrome? So the first neuron, the first question for me is, where is the first neuron coming from? Fast answers, please. First
Posterior
neuron.
hypothalamus.
Very
Hypothalamus.
good. It's coming from the hypothalamus to the ciliospinal center of bulge along this pathway. So what are the problems that can occur in this pathway? First of all, we can get a pontine hemorrhage, right? Then we can get lateral medullary syndrome. Which artery is associated with lateral medullary syndrome? Fast answers, please. Pica. There, very good. Next one is spinal cord lesion above T1. Okay, which we also call Brown-Sequard syndrome. So how many causes did we talk about? We talked about 3 causes. One was Pons, pontine hemorrhage, then lateral medullary syndrome, and then we talked about Brown-Sequard syndrome. These are very easy to understand. Okay. Next one is second neuron. Second neuron goes from the ciliospinal center of bulge to the superior cervical ganglion. And we know that the superior cervical ganglion is very close to the apex of the lungs. So what is the tumor that can cause second order neuron damage? Fast answers, please. I've underlined.
Ankos tumor.
Ankos tumor, very good. Third neuron goes from the lungs to the internal carotid artery, and then it reaches the long ciliary nerve to the dilator pupil. As a result, what is the cause of the third neuron damage? Third neuron damage cause, it's
Carotid dissection.
Very good. It's carotid dissection. Okay, so can I hear the causes of the first, second, and third order neuron very quickly, please? What is the cause of damage of the first order neuron? Number 1, we have
Pontine hemorrhage.
Pontine hemorrhage.
Number 2, we have
Lateral medullary
Lateral
syndrome.
medullary syndrome.
very good. Number 3, we have
Brown square.
very good. And then for the second order neuron, what is the number 1 cause of damage?
Pancreas tumor.
Ankos tumor.
Very good, very good. And for the third one,
Carotid dissection.
Carotid dissection.
carotid dissection. Very good, carotid dissection. Okay, so it's extremely easy. It's very easy. If you can know the pathway, you can know the causes. Next one is this ocular motility knowledge. Okay, but first aid does not know that we are very knowledgeable ourselves. Okay, so we do not need first aid to come and tell us that SO4 and LR6. Okay, this is a completely useless knowledge which first aid is trying to provide. Why is this useless? Because we already know this. Okay, SO4 meaning what?
Superior oblique.
Superior oblique by cranial nerve 4.
Okay, lateral rectus by
Cranial nerve 6.
6.
okay, and the rest are by
Oculomotor.
3.
oh,
Oculomotor.
okay, good. Okay, good. The only thing which we have to learn are the movements of the oblique. If the oblique muscle, let's say the superior oblique, if it contracts, in which way will the eye move? The eye will move
Down and in.
down
and lateral.
okay, good. And if the inferior one moves, then will it go up or down?
Up and median.
Okay, up.
Up and median.
Very good. Done. We're done with that page. Next one are the damages. Okay. First of all, let's talk about these 2 damages, the small ones, then we can talk about the big ones. First of all, let's talk about 6th cranial nerve damage. If the 6th nerve is damaged, which muscle is innervated by the 6th?
Lateral rectus.
Lateral rectus.
So will the eye be able to move? Which way will the eye not be able to move?
Laterally.
Laterally.
So eyes will not be able to adduct or abduct?
Abduct.
Abduct. So loss of abduction, right? Loss of abduction. Next one is superior oblique by SO4. If SO4 is not working, okay, if SO4 is not working, which way will the eyes be? I mean, the eyes be positioned?
Up.
Upward
They,
and medially.
Upward.
they
Right.
will not move infantry.
Okay. So you can see the roof or you can see the floor. Which one?
Can't see the floor.
You can't see the
You
floor.
cannot
You
see the
cannot
floor.
see
Okay.
floor.
As a result, what will happen is these patients will have a head tilt. Okay, these patients would tilt their head. Why? Why will they tilt their head? Because if they tilt their head, they can. So their position. So they're looking like this. Okay, so this is what their vision usually looks like. So if they tilt their head, okay, then the vision can be a bit on the same axis. Okay, then the vision can be on the same axis to some extent. So these patients will tilt their head to the unaffected side. Okay, so they will tilt their head. So let's say this is the affected side, they will tilt their head to this way. Okay, and this will result for them to get their eye axis in order. Okay, can we look at a patient with okay. Okay, do you see this boy over here?
Yes.
Okay, do you see the head tilt? Do you see the way the patient has tilted their head? Yes or no?
Yes.
Yes,
Yeah.
to the affected side or unaffected side.
Unaffected side, to the unaffected side. Okay, to the unaffected side. Okay. Okay, so this is what it is. Okay, so how will you get questions from over here? You will say questions about a patient who has diplopia and the patient has a problem looking at the floor, and the patients will have movement of the head towards one side. If you receive a question like this, which nerve is damaged?
4.
4.
Cranial nerve, that is damaged. That is your question. Okay, next one. Next one is third nerve damage. Okay, what are the things that we see in third nerve damage? First of all, what we have to realize is that the third cranial nerve has both motor and parasympathetic outflow. Okay, they have both motor and parasympathetic outflow. Okay, so first of all, let's talk about the parasympathetic one. Okay. Um, first of all, let's talk about okay, so first of all, let's talk about the motor one and the parasympathetic one, but before we do that, let's talk about the causes of oculomotor nerve palsy. Number one cause is ischemia. Okay, ischemia is basically you know what ischemia is, loss of blood supply. Then do you remember we talked about uncal herniations?
Yes.
We
Yes.
uncal herniation, how uncal herniation causes oculomotor nerve palsy. Okay,
Yeah.
next one is posterior communicating artery aneurysm. We also talked about this. Do you remember? Dr. Hussam was asking me what is PCOM-A
Yeah.
yesterday. Yes, we
Yeah,
talked
yeah,
about.
yeah.
Okay. So posterior communicating artery aneurysm. Okay, and then another one causes cavernous sinus thrombosis. Cavernous sinus, the nerve that goes through the cavernous sinus is 4, 5, 6. Okay, so cavernous sinus thrombosis, and it's another one. And then last one is a midbrain stroke. Okay, out of all of this, the important cause of oculomotor nerve palsy is PCOM aneurysm. For you world, for you world, PCOM aneurysm. Please put your stars over here. Okay, please put your stars over here. Okay. Now, if you have an oculomotor nerve palsy, it could either be a motor or parasympathetic. If it's a motor nerve, okay, which muscles will be affected? All the muscles that are except SO4. I mean, all the
And
muscles except
LR.
superior oblique and lateral rectus.
Lateral rectus.
Correct. Absolutely correct. Okay, that's what it is. So what would happen is they could be affected by vascular diseases. Example, diabetes, glucose. Okay, diabetes, and what happens is the glucose gets converted to sorbitol, which is an osmotically active substance, and this can cause damage. Okay, and we talked about the fact that you remember how we told you that if you have an oculomotor nerve palsy, if you have an oculomotor nerve palsy, I'm sorry, I don't know what I'm drawing over here. Okay, okay. So if this is the oculomotor nerve, okay, the motor stays inside and the parasympathetic stays outside. Okay, the motor stays inside and the parasympathetic stays outside. If this is A and this is B, okay, which of this will diabetes affect, A or B?
A.
Which of this will pressure or trauma or tumor affect, A or
B.
B? B,
B.
correct. So correct, that is good. So A is basically affecting the medial portion, which is the motor output. As a result, for diabetes, we have we have this accumulation of glucose. Glucose gets converted to sorbitol, and this osmotically active substance, it causes disruptions of both the oxygen and the nutrition. Okay, as a result, what happens is the patients have damage to all the other muscles except superior oblique and lateral rectus, and the patients have ptosis and down and out gaze, down and out gaze. Now, if we have a tumor or an aneurysm which is pushing on the oculomotor nerve, the outer part is involved, as you have just mentioned B. Okay, as you have just said B over here. So according to you, that's exactly what's happening. So if you have a pressure affecting this, the outer portion is more affected. As a result, the patients will have loss of parasympathetic supply. And which one is the parasympathetic? What happens in parasympathetic? Do we have pupillary dilatation,
Mydriasis.
pupillary constriction?
Dilatation.
Okay, now
Dilatation.
Bronchial.
if we, okay, now
Sorry.
with the pupillary light reflex, will there be absent or presence of pupillary light reflex?
Absent.
Absent of
Absent.
pupillary light.
Absent. Yeah.
Absent. So have you guys understood about oculomotor nerve palsy?
Yeah.
Okay, so oculomotor nerve palsy, basically what's going on over here is, okay, so basically what's going on over here is if you have an oculomotor nerve palsy, what's going on is either you have a motor output damage or you have a parasympathetic output damage. If you have a motor output damage, how will your eyes look like? How will your eyes look like?
Down and
Past
out.
tenses, please. Down and
Down
out.
and out.
Okay.
Down and out.
Very good. And if you have a parasympathetic output damage, if you have a parasympathetic output damage, how will the eyes look like?
Down and out.
Mydriasis.
Okay, good.
Mydriasis.
Which reflex will be absent?
Light effect.
Light.
Light reflex. Pupil light
Very,
reflex.
very good, very good. Okay, and we are almost done. Almost. We are almost done with ophthalmology. So we did quite a lot for today. Okay, we did quite a lot. We finished ophthalmology. Okay, we started our lecture at 9 a.m. We are very close to finishing ophthalmology, and this is the last thing which we have to master before we finish the whole thing. Okay, do we have any student who has just joined us? Do we have any student who has just joined our lecture? Anyone?
Yes, please.
Okay. So welcome to our lecture. I'm just going to mute you all. Okay. If you have anything to write, please write in the chat box. Okay. So the thing is, welcome to our lectures. Okay. I apologize that you had to join our lecture so late. Okay. But what we can do is, since you have missed out on majority of the lectures for today, please send us an email and we would be more than happy to provide you a recording so that you can see the lectures for yourself. Okay. And that's that. Okay, so always remember, please, that our lecture starts at 9 a.m. and our lectures end around 1:30 to 1:45. Okay, and our lectures are from Monday to Friday, New York Eastern timing, from 9 a.m. to 1:35 to 1:40 p.m. Okay, having said that, let's begin. Okay, last one which we want to discuss is the cavernous sinus thrombosis. Okay, please just give me 1 minute. Okay, so we would discuss cavernous sinus thrombosis. Okay, first of all, before we discuss cavernous sinus thrombosis, all the students can unmute themselves right now once again and answer my questions if needed. Have I discussed cavernous sinus thrombosis with you guys before? Yes or no?
No.
Anyone?
No, but we mentioned it.
Right. We talked about cavernous sinus thrombosis once. Where did we talk about?
Maybe when we discussed the venous drainage of the brain.
Okay, no problem. So we will try to master the cavernous sinus thrombosis right now. Okay, so this is the first structure I'm going to draw. This is just, okay, so this is the pituitary. First of all, let me just draw the boundaries of the cavernous sinus. Okay, so this is okay. So the cavernous sinus is one of the most important structures of the brain. Okay, this contains a major group of nerves. Okay, and these group of nerves, out of all of them, can you guys tell me which nerve is the most longest nerve?
Cranial nerve 6. abducens.
Abducenness.
Okay, very good. Okay, and the reason why I'm drawing this diagram is because the position of the nerves are extremely important, and you will be asked whether you know that which nerve is placed in which position. Okay, so this looks more or less like a butterfly over here. Okay, so what's going on over here is, first of all, this structure over here, this is our friend pituitary gland. Okay, this is our pituitary gland. Okay, so the cavernous sinus are on both sides of the pituitary. Okay, first of all, if this is the pituitary, can you guys tell me what white matter tract this is?
Optic chiasm.
Very good. Very good. This is optic chiasm. Okay, so this is the optic chiasm. This is the first structure. First structure is optic chiasm. Okay, next one. Next one is, okay, the next one is uh, we have the nerves. Let's talk about the nerves first. Okay, so the nerves are basically placed in order. So the first nerve that is over here, okay, the first nerve that is over here, this nerve, okay, what is the name of this nerve?
Oculomotor.
Very good. It's third cranial nerve. Are you sure you're not looking at the book and giving me the answers?
Yeah.
Okay, no, do not look at the book. Then what's the purpose? There is no point. Okay, there's no point in looking at the book and giving me the answer. Try to figure out from your own knowledge, because I told you guys before that the cavernous sinus, it contains oculomotor, trochlear, V1, V2, and 6. I have said this before, correct? Do you guys remember that?
Yes,
Okay.
yeah.
Yeah.
If you guys remember that, then first of all, what is this structure? Optic chiasm. What is this structure? Oculomotor. What is this structure?
Four.
Take a wild guess. Take a wild guess.
Ocular.
Trochlea.
Very good. What is this structure?
B1.
5.
V1.
Okay. V1. What is this structure?
B2.
Okay. Now there is another structure over here. Okay. There's another structure. So the thing is, the sixth cranial nerve, it is an extremely long cranial nerve. So there's not enough space over here in the cavernous, in this part of the cavernous sinus to go through below the fifth. So the abducens nerve, it goes through the abducens nerve, it goes through this side. So this one is your abducens nerve. Okay, this one is your abducens nerve. Okay, so we are done with the nerves. We have the optic chiasm. We have third, fourth, V1, V2, 6, and now all we have to do is draw our arteries. Okay, one of the major arteries that we have over here is, do you guys have any idea what the name of this artery is? Please do not look at the book. Make a wild guess. Anything?
Internal carotid artery.
Okay, no, it's not internal carotid artery, it's anterior cerebral artery. Okay, this artery which stays here, this part of the cavernous sinus, this is supplied by anterior cerebral artery. Okay, and this artery over here, and this artery over here, these are the same arteries. What are the names and branches of these arteries that are in the middle? That's not middle cerebral.
Middle cerebral.
No,
Ophthalmic. Ophthalmic.
no, these are internal carotid arteries. Okay, so we have internal carotids and anterior cerebral artery, but the arteries are not that important. The most important ones are the nerves. Okay, so if you have to know about the nerves, then always remember the third is the number 1, fourth is number 2, V1 is number 3, V2 is number 4, and then the last 6 is over here. Okay, so if you get questions in your NBME, first of all, now let me ask you very quick, and I want some very quick answer. This is just a part of the cavernous sinus. Okay. Okay. Easy, easy, very easy. Okay. Okay. So what is the name of this nerve?
3,
Oculum.
What is the name of this nerve?
4,
Four.
Nerve?
B1.
V1, V2,
What is the name?
V2.
B2.
What is the name of this nerve?
6,
Abducens.
That one
That's
is
it.
not.
Okay. Okay. Now you guys should be absolutely confident about cavernous sinus. Okay. And now if there's a cavernous sinus thrombosis, then there should be a problem with these nerves over here. Having said that, let's read the text. So what is cavernous sinus? These are collection of venous sinuses on either side of the pituitary. Okay, so sinuses on either side of the pituitary gland. Okay, and blood from the eyes and the cortex goes through the sinus to the internal jugular vein. Okay, these are not important. Don't worry. If it's important, I will tell you. Then third, fourth, V1, V2 plus postganglionic sympathetic fibers, they all pass through the cavernous sinus. Okay, and the cavernous portion of internal carotid artery is also here. So internal carotid. So they basically they're just telling us all the things that we already know. What do we know? We know that the cavernous sinus are present on both sides of the pituitary. We have the arteries, we have these nerves. Okay, and now we have to talk about one very important pathological condition, and that is cavernous sinus syndrome. And that is basically this presents with various ophthalmoplegia. Why does it present with ophthalmoplegia? Because most of the nerves that innervates the muscles of the eyes, that is third, fourth, and sixth, all of them are over here, right? So
Yeah.
any one of them, if this gets damaged, then the patients will get ophthalmoplegia. Along with this, the patients can also get Horner syndrome, right? Because once again, the muscles, because it contains the superior sympathetic ganglia, okay? Okay, and there could also be decreased maxillary sensation. Why? Because why will the patients have decreased maxillary sensations? Can I get some
V2.
fast? Very
V2.
good, very good. Because this with this
Trigeminal
friend over here.
transfer.
Okay, right. And what are some other causes of cavernous sinus thrombosis? Tumor. Okay, we can also get fistula, and that's what it is. Okay, so having said that, now next time if anyone asks you what are the nerves that are present in cavernous sinus thrombosis, what is, I mean, in cavernous sinus, what is your answer?
From 3 to 6.
3 to 6.
3, 4, V1, V2, and 6. Okay. Okay, and with that said, are we done with ophthalmology? Okay, we are done.
So doctor,
We,
they just ask concerning the nerve contents, and that's it.
which one?
Their questions about the cavernous sinus is just about nerves.
Yes. Yes, the questions about the cavernous sinus are just about the nerves. Questions about the cavernous sinus are just about the nerves. Okay, they're just about the nerves and where the nerves are placed and what the location of the nerves are. Okay, so the thing is,
Excuse me, doctor. Somebody waiting. Sorry.
where?
Wait.
Nope, everyone is here.
No. Okay. So okay.
Okay, thank you for helping us out. Okay, that's what it is. Okay, so that's that. Okay, so I'm just going to mute you all once again. And before I mute you guys, thank you so much for helping me out finishing ophthalmology and answering the questions as soon as I asked them. Okay, so I can see a lot of students, they already got exhausted and they left. But for all the students who left, you have nothing to worry about. Okay, I will give you guys the recordings. If you are a subscribed member, then you will get the recordings, no problem. Okay, and if you are not, then please subscribe to our channel, and obviously you will. Okay, so that's what it is. Okay, for the new student who has joined our lecture for today, we started our lecture at 9 a.m. and we have been trying to finish neurology, and we did finish neurology. Okay, so we will start with neuropharmacology from tomorrow. And if you continue with us in the future, then we will cover the topics which you have missed, and we will take lectures on them again. So you have nothing to be worried about. Okay, having said that, okay, I think it's 1:40 today, and we have had a lot of knowledge thrown at us from the beginning to the end. Do you think it's about time that we should call it a day? Do you think it's about time that we should call it a day and end it? Okay. Okay, so was I successful in teaching you guys ophthalmology from the beginning to the end in as easy as possible? Because God knows I tried my best. Okay. Okay. Okay, so thank you so much for putting your time and putting your attention in the lecture. Okay, for putting your time and putting your attention in the lecture. And hopefully, okay, before you guys leave, is every one of you confident with ophthalmology questions? If you receive questions regarding ophthalmology, are you guys confident? Okay. Okay, good. Good, very good. So that's what it is. So having said that, our last lecture for tomorrow is on Friday. Our last lecture for this week is tomorrow. Okay, our last lecture for this week is tomorrow, and After tomorrow, next week, we will be starting with another new topic. Okay, we will be studying with another new topic, and hopefully, we will not be taking so much time like how we did with neurology. Okay, we took our time with neurology because this was high yield, but I'm extremely glad that we are finished with neurology and we can move on. Okay, if you guys have any other questions or concerns, please let me know in our email address, and um, we will give you your answers. Okay. So with that being said, thank you so much. If anyone has any question, they can ask me now regarding USMLE, regarding our lectures, and regarding anything. If you guys like our lecture, please, please, please give us a rating on our Facebook page. Okay, give us a rating, give us a recommendation, give us some feedback. If there's something which you want us to change or do, please let us know on our page. Okay, because we require reviews and ratings and stuff. Okay, so if you like our lecture, then only then and then only can you provide uh, the rating. Okay, so we have another question. Can you repeat why damage CN3 is down and out? Okay, down and out, please. Okay, so basically, what is the okay? So superior oblique. So CN3 will damage superior oblique. Superior oblique is responsible for, okay, superior oblique. If there's a superior oblique damage, okay, superior oblique movement is okay, up and in. So basically, if the superior oblique, okay, so let's say, okay, in the superior oblique, 1 second. Okay, if this is the eye, then this is the superior oblique. Okay, if the superior oblique constricts, the eyes will move. Okay, if the superior oblique is not working, the eyes will move down and out. Are we clear? Are we clear now? Superior oblique. Dr. MS, are we clear now? Yes, we were talking about superior oblique. The superior oblique is innervated by CN4. You wanted to know about the superior oblique damage or the oculomotor nerve damage? Which one? Oculomotor nerve damage. In oculomotor nerve damage, if the superior oblique is working, then which way will the eyes move? Okay, once again. If this is your eye, okay, if this is the superior oblique, okay, if the superior oblique constricts, which way will the eyes move? This A or B? Can I get some fast answers, please? Which way will it move, A or B? B, exactly. So that is correct. So superior oblique, when will it work? Will it work with oculomotor nerve? Okay, so superior oblique, what happens is superior oblique, it works when oculomotor nerve is not working. When oculomotor nerve is not working, because oculomotor nerve supplies superior rectus, right? Middle rectus, inferior rectus, and when those are not working, superior oblique muscle overcompensates or compensates and then moves the eyes down, down and out. Okay, so that's why the eyes move down and out. Are we clear now? Okay, you are welcome. Okay, you are welcome. Okay, so having said that, does anyone have any other question? Of course, please ask her to send us an email to, okay, Okay, we are done for free lectures. We do not have any more free lectures because that's that. But please ask her to send us an email and we will help her out with whatever she needs. Okay. Um, let's see if, okay. So the only way we can get free lectures is if any one of the students are willing to join, if they make their transactions for next week earlier, then we can get free lecture for them only then and then. Okay. But no problem, Dr. Dahlia, since she's a friend of yours, please ask her to send us an email and we will help her out. Okay. Does anyone have any other questions? Okay, Dr. Dahlia, did you hear my answer? Okay, since she's a friend of yours, okay, please ask her to send us an email and we will try to help her out. Okay. Okay, you are absolutely welcome, Dr. Hussam. Okay, you're absolutely welcome. And okay, so having said that, thank you so much. And hope you guys have a great day today. Please solve the UWorld questions. If you guys have any questions regarding our lectures, please send us an email. If you guys like our lecture, please provide us reviews and ratings on our page because we need your help. Okay. And having said that, I'm going to take my leave and I will provide the recordings for this lecture to you guys today. And I will provide the Zoom URL for tomorrow. Okay. So, okay. I'm going to take a leave and hope you guys have a great day once again. Okay. Bye bye for now.